Good morning, everyone, and welcome to today's Continuing Education. It is the 25th Mass Health Council Pharmacist Public Policy presentation, and we've been doing this every year in the hopes of opening and enhancing pharmacist knowledge of what's going on in the world of public policy. My name is Dennis Lyons, for those of you who don't know me, and I'm the co-chair of the Pharmacy Committee with Mass Health Council and the principal of DGL Healthcare Consulting, located in beautiful Falmouth, Massachusetts, over my garage. Anyway, as many of you are aware, the Massachusetts Health Council is a nonprofit advocacy organization dedicated to the provision of quality health, access, and disease prevention. Over the past years, the Pharmacy Committee has striven to present this annual program, which presents timely public topics and access to individuals who are in positions to impact the profession of pharmacy and the patients we serve. This year is no different, as we are presenting in today's program timely topics regarding gender-affirming care for pharmacists, counterfeit medicine in the supply chain, child and adolescent mental health treatment, in our update information on pharmacists administering of vaccines in our annual Board of Pharmacy update and public health. We hope that you will learn and benefit professionally from today's program and take back important information provided by a highly qualified panel of speakers. I would like to thank the members of the Pharmacy Committee who provided input into today's program, and especially my co-chair, Kathy Keogh, Atrius Healthcare. Kathy, I hope you're out there listening. I would also like to recognize the hard work of David Martin, our executive director, and his staff who worked to put this program on, as well as our CE partners, the University of Rhode Island School of Pharmacy Continuing Education Program. This morning, I would also like to recognize Todd Brown, who is doing the 2023 vaccination update today. As many of you know, Todd has served for many years as the executive director of the Massachusetts Independent Pharmacists Association and has been a tireless advocate for independent pharmacy all over the state. Todd is retiring this year from both his position at Northeastern University College of Pharmacy and as head of MIPA. I would like to publicly thank him for his dedicated service over the years to the profession of pharmacy and wish him the best in his new home in Florida. Good luck to Todd. And now, without further delay, I would like to announce David Martin to continue the program. David, back to you.
Dennis, thank you very much. Welcome, everyone. We have a great turnout today. We have over 300 attendees for our program. I want to give a quick shout out to one of our sponsors, Pharma. We can't pull these programs off without support from our sponsors. So thank you very much to them. I also want to give a quick plug for a program that's put on. I'm going to put it in the chat right now. By the Department of Public Health here in Massachusetts. It's a program that educates pharmacists about the access law, which was a law passed in Massachusetts that gives access to contraceptives. And it's information about how pharmacists can understand better about how the program works. So please, if you follow that link in the chat, it'll bring you to a page where you can register for the CEs that you can get. You take an online CE class run by the Department of Public Health. That educates pharmacists about the access law. So that's really great. A quick reminder, this is a webinar format. So you can only see us, we can't see you, and your cameras are not active and microphones are not active. So if you have questions, put them in the chat. And then I will try to assist each of the panelists in looking at questions as they come through. So if a question occurs to you during someone's presentation, you can feel free to put it in the chat. We'll try to keep on top of it. But then most panelists, I think, will try to answer their questions at the end, but they'll probably announce that just before they get started. So with that, let me look quickly in the chat to make sure I'm not missing something that someone wants me to address. Great. So let's get started. I have the great privilege of introducing our first panelist, Julie Thompson. Julie is a PA. She's a primary care clinician. She is the medical director of the Trans Health Program at Fenway Health, which is an amazing organization right in the heart of Boston that serves very vulnerable populations. And Julie's going to give us a talk on Introduction to Gender Affirming Care for Pharmacists.
All right, thank you so much, David and Dennis. I'm so happy to be here. I'm just going to take a moment to share my screen and do a little play here. All right, fantastic. So thank you so much. Happy Tuesday morning and start to your symposium. I'm so excited to be talking about gender affirming care. I love talking about this topic, and I've actually never spoken to pharmacists about this topic. Well, not specifically to pharmacists. And so, in thinking about doing this, I'm so excited. I think for a while, I've taken it for granted. We have a pharmacy at Fenway Health, and I think I've taken them for granted in terms of knowing that our patients, once they leave my office, are able to access their medications, ask questions in an affirming way with pharmacists who really have knowledge about these medications. So I'm really excited to kind of expand this network and know that my patients can get this care and be able to ask questions and have pharmacists who really understand how important this medication is, not just in Massachusetts, but Rhode Island and all around. So thank you so much for having me. So I'm going to start out with this talk really at the basis, really talking about gender versus sex, talking about language, the importance of affirming language, just to make sure we're all starting out really kind of on the same plane and on the same base here. And then I'm going to talk about, how we approach starting gender affirming medical hormone therapy through the lens of informed consent, and sort of a little bit about those conversations. And then I'm going to go into kind of the heart of, what are the medications, what are the medication options, kind of dosing expectations, and then some considerations of risk. And then hopefully throughout this whole talk, really inferring the importance of, the medical necessity to accessing this care and these medications. So, jumping right in, I'm going to start off talking about sex and gender. And I think this is really important, these distinctions. Often these terms are used interchangeably, but they're really different, right? And if we think about it, in our everyday life, thinking about our electronic medical record, that M to F that's up in the corner, is that a sex marker? Is it a gender marker? These are all questions that are really important and that we actually make a lot of assumptions about. But again, sex and gender are very different. So when we're talking about sex, we're really talking about biological difference. We're specifically talking about things like anatomy, chromosomes, hormones, genes. But we're talking about gender, these are really social and cultural distinctions, right? We're talking about gender identity, gender expression, gender roles, which are really psychological, behavioral, environmental, cultural. So, really, again, very, very different what we're talking about. And really not being able to make assumptions from that M to F, right? And so I'm going to dig a little bit deeper into that. And I'm going to talk today a lot about gender diversity, but I also like to make a plug that sex is really diverse as well, right? If we think about nature, everything's a bit diverse, right? And so, gender diversity, but also sexual diversity, if we think about our intersex conditions, about 2% of the population is intersex, which is about the same percentage that are redheads in the world, right? So I'm going to spend all my time today talking about gender, but I just like to make sure everyone knows that, all of these things are diverse and multidimensional, and I find really, really exciting to think about. So gender identity, what is it, right? So gender identity is an internal sense of ourselves, and specifically an internal sense of our gender. And gender expression is actually how we present that, right? It's how we present it through our behavior, our mannerisms, our speech, the way we walk, the way we talk. And so often, right, we're presenting our gender every day, right? We dress in a certain way, we cut our hair in a certain way, we talk in a certain way, because we want the world to see us as we see ourselves and we feel ourselves, right? However, we have to be thoughtful that there are going to be folks who don't feel safe actually expressing their gender, right? It might not be safe in the social environment they're in. They might not be accepted, or might not feel safe expressing their gender. So it's really important that we're not assuming someone's gender identity based on their gender expression, right? We really need to ask folks how they identify their gender. And then if we a little bit into terminology, If we think about transgender, so transgender is what we call an umbrella term, meaning that sort of encompasses sort of anyone whose gender identity is not congruent with their sex assigned at birth. Right? You may have also heard of the term cisgender, right? And cisgender really identifies anyone whose gender identity is congruent with their sex assigned at birth. And these terms, trans and cis, are really sort of chemistry terms or Latin terms, with trans meaning on the opposite side of and cis meaning on the same side of. So that's really where that terminology comes from. And we talk about how do we talk about other folks, right? Or how we write about folks in the medical record. The best way, the key way, right, is asking people how they identify their gender. And when we ask folks that question, whatever they say back, we want to make sure we're using that terminology. That said, I'm going to give some broad kind of language that is usually acceptable to use. And I will say these terms change all the time, right? It's not uncommon for these terms to change on a year-to-year basis. It'll also probably change depending on what region you're in. I also find that older folks and younger folks have different terminology and different language. But anyway, so I'm going to give sort of a basis here. So for someone who was assigned male at birth, but is affirming a female or feminine identity, some of the terms we might use are transgender woman or trans feminine individual if someone's not identifying right on the binary, or a woman of trans experience. So there are some folks who fit under the definition of transgender, but someone may no longer identify as a trans woman. They don't like that adjective anymore. They're just identifying as a woman. But us in sort of the medical field, we may find that trans experience or trans history is relevant to their medical, the medical things that we want to think about. So we might write a woman of trans experience. Okay, and so similarly, someone who is assigned female at birth, but is affirming a male or masculine identity, we can use transgender man, a trans masculine individual, or a man with a trans history. And you'll see that I have M to F and F to M here in gray. These are sort of older terms, really. So what they mean is male to female, female to male. These are sort of older terms we might see in the literature still. Some people might still be using them. But really this term M to F or F to M, it connotates moving from one box to another box. And that really doesn't capture a lot of people's experience. And so that terminology is sort of coming out of favor. And so again, sticking with the ones that I just mentioned is really sort of more acceptable. There's also folks who identify not as a man or a woman, or even sometimes as masculine or feminine, right? Someone might identify as non-binary, genderqueer, gender fluid, or even agender. These might be some terms that you've heard, and these are not all of the terms, right? There's lots more. And then you may have also seen the acronyms AMAB and AFAB, and these stand for assigned male at birth and assigned female at birth, respectively. Now, most people don't typically identify themselves as identify as AMAB or identify as FEMAB, AFAB. But really these terms or these acronyms are more used sort of in the medical, I would use them sort of in my note writing. And so for example, if I had a patient in, I might say, I have a 24-year-old non-binary AMAB individual here to see me for hormone therapy. So giving that extra information of AMAB kind of might give us some idea in terms of, okay, what hormones are we talking about or what surgery are we talking about? So that's really where that terminology is most used. And sort of to stick with non-binary identities for another minute, I do because this is a really growing portion of the population, right? The folks who are identifying as non-binary, and they tend to skew kind of younger. So this data is actually from the 2015 US Trans Survey, a really, really important survey that was done with trans and gender diverse folks all across the United States, actually surveyed 27,000 individuals. Really important survey, actually, if you haven't taken a look. It really asked trans and non-binary folks about all sorts of lived experience, from experience in medical care to schools to prison systems, religion, all sorts of things. So really, really important document. Anyway, when they asked folks how they identify their gender, just as many people identified as non-binary as they did as either transgender man or transgender woman, okay? And again, mostly younger populations. So really important for us, right, as medical providers, that we want to make sure that, again, we're not assuming someone's gender based on how they look or assuming someone's identifying on the binary as a male or female. We're really asking people how they identify, right? And also making sure that our paperwork, our medical forms are really thinking about this aspect of folks' identity and making sure that we create a space where folks can be seen for how they identify. So when we talk about, what does it mean to transition, or what does it mean to affirm someone's gender identity? Well, there's not really one way to do it, right? So there can be a social process, a legal process, a medical process, and some folks might choose one of these or a couple of these, or someone might choose to fully identify or affirm their gender through all of these means, right? So we think about social affirmation, we're thinking about being out in the world, right, as your authentic self, right? So using the names and pronouns you most identify with, folks are seeing you in the community, again, as the person and as the identity that you affirm. Legal might mean changing your legal documents to the name and the pronouns and the gender marker that, again, you identify with. So we're thinking about passports and licenses, social security, even birth certificates we can adjust. And medical, which I'm going to talk mostly about today, may include hormone therapy and surgery. And just to say, I really like the term gender affirmation more than transition. Again, transition, I think, again, is sort of back to that idea of moving from one box to another. And I love the idea of affirming someone's gender. The definition of affirm means to validate, right? I like the idea of validating and affirming someone's gender wherever that might be, and whatever aspect that might be, whether it's social, medical, legal, or all, or some. All right, so in talking about hormone therapy, really for most folks, the goal is to create a hormone milieu or hormone environment or physical appearance that's in line with a person's internal sense of themselves, right? And so for someone who's assigned female at birth, but affirming a masculine identity, I'm going to talk a little bit about testosterone therapy as a medical affirmation. And for folks who assigned male at birth and affirming a feminine or female identity, I'm going to talk about we're going to talk about estradiol, and I'm also going to talk about anti-androgens, which in the United States, we'll talk about spironolactone. And so in terms of having these conversations and these initial sort of conversations with patients in terms of starting on hormone therapy, we use what's called the informed consent model. I think that there's a connotation with consent models or consents that it's sort of a procedural consent that you're reading kind of the risks and benefits, you're signing off, and all risk is now signed away. And that's really not how we approach this, right? That when we talk about informed consent, we're really talking about the communication or the discussion sort of back and forth between the provider and the patient to really go through risks, benefits, alternatives to care, and patient goals, right? And this is a really individualized approach, right? Based on different learning styles and abilities. So I take a lot of time in the visits talking to patients, but I also know, and I'm sure you have the experience, that when someone's excited or nervous in an appointment, you're talking a lot, a lot of that information goes out of the head. So I also make sure that I provide handouts, I provide other resources or even webinars or videos. So lots of different ways to do this learning. I also want to make sure I understand someone's medical literacy and comfortability. I have folks who know everything there is to know about hormone therapy. They're finishing my sentences. And I have other folks who don't have as much knowledge about hormone therapy yet. So those conversations are going to be very different. There's also age appropriateness. If I'm talking to someone who's 20 years old versus 60 years old, my conversations are going to be very different, specifically when it comes to something like fertility or reproductive health, right? And then there's also the goals of care, right? Again, I want to understand my patient's expectations and also talk about the knowns and unknowns in literature, right? And this is an ongoing process, right? Every time I see my patient, right? If I learn something new or we're talking about something new in terms of goals or hormones, I'm going to continue to talk about these risks and benefits. And this is the beauty of, why I love doing this work within primary care, because I'm also thinking about preventive health. And these are conversations I'm also having. I also think that the informed consent model is an amazing way for me to know my patient and my patients to know me, because what I'm going to talk about and what I want to know is my patient's priorities and goals, right? I'm not coming into that appointment with an agenda, right? I'm there just to support my patient wherever they are. And so I'm going to ask, what are your priorities and what are your goals for care? What are your expectations for hormone therapy? And this is a way for me to understand, are these expectations reasonable? How much education am I going to need to do? And this is all an important part of, again, the informed consent process in these conversations. And it's an awesome opportunity, again, for me to really understand and support my patient wherever they are, because in asking a lot of these questions, I'm getting a lot of knowledge, about how I can support my patient to the goals and where they need to be. So again, when I talk about medication specifically, this is really individualized. You'll hear me say individualized a lot because it really is individualized care. I truly think that this is the art of medicine. And individualized in terms of hormones, because all people, whether you identify as trans or if you're a cisgender person, all people have varying amounts of hormones in their body, right? And that's going to be the case too when I'm prescribing hormones for trans folks and non-binary folks. And I try to make the point too that what's necessary for some folks or affirming for some is not necessarily for others, that physical and emotional responses to hormones are going to vary. There's also, when we're thinking about different hormones and different doses, we also have to consider underlying risks, and everyone's going to have a different family history or comorbidities, lifestyle changes. And then we also have to think about the kind of concrete, things like, cost of medications, and does someone have insurance, right? We have to think about access to care. Can you come into the clinic for monitoring? Do you have access to a pharmacy? The frequency of dosing, right? How often do you want to dose something? Do you have needle phobia? So these are all conversations and questions I'm going to ask as well. And just to say too that I hope you wouldn't think this anyway, but this is not the be all and end all of all the information that you can have. There's lots of literature out there, both for patients and for us as providers. And so I wanted to share some of these with you so that you have, this information when you leave here. So lots of health centers who do this work like Fenway Health, and also I love to promote UCSF. So the University of California, San Francisco has a Center of Excellence for Transgender Health. We all have our individual sort of guidance or protocols. They're very similar, but they're important to kind of look through. And these are all accessible online. I really plug the UCSF protocols. It's really easily searchable. It's very well cited. Our protocols are great too. The Endocrine Society has great guidelines. And really importantly, WPATH, which is the World Professional Association of Transgender Health, which is an international sort of body of researchers, medical providers, behavioral health providers, produced a document called the Standards of Care. The Standards of Care version 8 was just published in September of this year. This is a really, really important document because it sets the standards, as I said, internationally, but it also is the main document that insurance companies use to kind of decide what coverage is medically necessary, both for hormone therapy and surgeries. So it's a really important document to be familiar with. It's pretty easy to read through, amazingly enough, that each chapter kind of has a summary. And again, available online for free. So I strongly encourage you, if you do this work, and you should, and I'll continue to harp on that, it's a really important document to be familiar with. All right, so I'm going to jump into talking about hormone therapy. So as I said, for folks who are assigned female at birth, but affirming a male or masculine identity, we're going to talk about testosterone therapy. I'm sure you know testosterone is a pretty strong hormone, so testosterone itself is usually alone enough to sort of suppress estrogen and sort of affirm, again, creating that hormone milieu or environment of physical changes, sort of more in line with someone's gender identity. So I'm going to start off talking about injectable testosterone. So this is probably the most common form of testosterone that I prescribe. One, because it's the cheapest, and two, because it works really well. So testosterone can come in two different formulations. So testosterone enanthate and cypionate. The main difference between these two is really the oil that it's suspended in, with cypionate being suspended in cottonseed oil and enanthate in sesame oil. A cypionate I prescribe most often. It tends to be cheaper and more readily available. This can be dosed intramuscularly or subcutaneously. Whether you dose IM or sub-Q, it doesn't matter. There's not going to be a dose adjustment. It's just really the way, the size of the needle and where you're injecting is really the difference there. And most, you can dose either every week or every 2 weeks. There are pros and cons. I have this little graph at the bottom. If you dose every 2 weeks, it's really this red line. The nice thing about dosing every 2 weeks is that it's less injections, right? You're only doing 2 injections a month. But in order for the medication to last the 2 weeks, you're giving a slightly higher dose. So it's going to have a higher peak, and the peak and trough, the difference between the two is going to be wider. So some folks who are really sort of sensitive to their hormone levels, that up and down, that peak and trough, that wide peak and trough might not feel as comfortable. So folks may decide to dose weekly, that this sort of green up and down, this green line here, where that peak and trough is a little narrower. And sometimes that feels a little bit better to patients. They don't get that kind of wide up and down of their hormone levels. I also, there is an auto injector as well that I wanted to mention. This is brand name only, but the auto injector can be really helpful for folks, particularly those who have whether physical or site issues that don't allow folks to draw up the testosterone into a syringe or can't necessarily see the markings on the syringe. The auto injector comes in three different doses, and it's a subcutaneous injection of testosterone enanthate. Some folks who have needle phobia also find the auto injector to be really helpful. It is much more expensive and so will require prior authorization. And I've had a little bit of a harder time getting this covered for my trans and gender diverse folks. But it is a really great option. And I do know folks who have been able to get it covered. Other formulations of testosterone can come in transdermal options, and these are patches or gels. These are all dosed once daily. So sort of going back to this graph, if we look at the blue line, now we're thinking of the transdermal applications that are daily. And so this sort of more follows that cisgender male sort of natural daily testosterone pattern. So for folks, again, who are really sensitive to their hormone levels at up and down, sometimes gels or patches are a bit better because it's daily dosing and even dosing. I would say I probably prescribe gels and pumps and packets more than I do the patches. The patches I find to be a bit more expensive. I've also had many of my patients who have been on patches get a pretty bad skin reaction from the adhesive in the patches over time. So I rarely prescribe those actually. That said, most folks do pretty well with the testosterone gel. It's rubbed into the upper arm once a day. Typical dose is typically 2 pumps of the gel or 1 packet of the 50 milligrams. If folks prefer kind of a lower and slower dose, of course, you can do 1 pump a day, or you can do kind of the lower dose 25 milligram packet. I would say that some of my patients are a little bit leery to try this. They've heard that if you're on the gel, it's all over your house and your walls and your clothes, and your pets and your partners are going to get testosterone on all over them. I try to, say it's not, you do have to be a little bit more thoughtful about the application when you're using gels. You have to wash your hands well after. The gel usually dries within about 5 minutes, but can take actually about 4 to 6 hours to fully absorb in. So thinking about when you do apply the gel, do it at a time when you know you're going to put a shirt on, you may go to work or go do something else. If you're sort of spontaneously sort of intimate with a partner, or you decide to go swimming or something like that, you can either cover the area, you can wash it off with soap and water. So these are things. The times I really don't prescribe the gels are if someone has a small, really an infant at home that you might be kind of holding and they kind of suck on your shoulder and things like that. Then I don't think it's appropriate. But most other times it's okay. There's also a 2% pump that's an axillary application of testosterone. And I would say, again, in my sort of 12 years of doing this work, I've never really prescribed the axillary application. Again, I find more than anything, it's the cost that I don't find is worth it for many folks with this. So I rarely prescribe it, though I'm sure it is an option. But usually I stick more with the pumps and packets. There are some long-acting formulations of testosterone. So that comes in the testosterone pellets and testosterone undecanoate. These are really awesome options for patients, although I will say the main barrier is they're super expensive. They're each about $1,000 per insertion or injection. So the pellets, you usually insert anywhere from 8 to 12 pellets into the subdermal space. So meaning goes under the skin, but above the muscle in the lateral buttock. So you think about the outside of your back pocket on a pair of jeans is sort of where it goes. They dissolve under the skin over the course of about 3 to 4 months, and then you put new pellets in. So you really kind of deal with doing this about 3 to 4 times a year. So really cool option. Testosterone undecanoate, sort of a whopping injection, it's about a 3 mil injection into the glute. It's done once, then it's done at a 4-week loading dose, and then every 10 weeks after that. Again, super expensive. I will say in Massachusetts, thankfully, our policies are fantastic. Private insurances and actually Medicaid tends to cover these with a prior auth. So we actually have lots of people on the testosterone pellet. And again, really nice option, especially for folks in college who, are only home on breaks or travel or study away. You don't have to take all your stuff with you when you travel. Really cool option. And then finally, I'll talk about this relatively newer option of testosterone. It's an oral formulation. It was FDA approved in March of 2019. This is an oral formulation, unlike other ones, right? So prior to this medication, other oral formulations of testosterone were not really used because of the risk of hepatotoxicity with methylated forms of testosterone. This particular form of testosterone was created in such a way that it's metabolized actually in the gut, so it doesn't go through first pass metabolism. It actually does not necessarily promote or cause any sort of liver hepatotoxicity. It does need to be dosed twice a day and with food ideally. I've found that a lot of my patients, particularly my young patients, have a really hard time dosing something twice a day, and particularly with food. Their lives are busy and chaotic. So I haven't had much success with folks on this. It also is very expensive, so will require a prior authorization. And I've had some folks say that they've had some burping or belching with it, kind of a terrible taste in the mouth. So sort of had a hit or miss with this oral formulation. But, for someone who does take medications already twice a day, really can't tolerate injections, this is sort of another option that you may see be used more and more. I did want to touch on some other medications besides testosterone that may be used for gender affirming care that you may see sort of cross your paths if you're wondering why, right? So estrogen cream can be used for atrophy of the frontal canal or the vaginal canal. I use the word frontal canal as more of sort of a broader term, as some folks don't necessarily like the word vagina or kind of feel comfortable with that part of their body. So using frontal canal, I try to stick with. So for folks who have been on testosterone for a variable amount of time, but usually over a year, usually over several years, the testosterone is suppressing estrogen. And what can happen is very similar to a cisgender female postmenopausal individual, where you might get atrophy of the vaginal canal or frontal canal and even the cervix. And so when that happens, folks may start to experience some discomfort with sex, may have some postcoital bleeding, or even just random bleeding just with exercise or rigorous activity. So estrogen cream just locally to the area can help bring back some of that moisture and elasticity to the area, making that more comfortable. And usually that just a localized estrogen to the area won't, refeminize or cause any problems. So if a patient feels comfortable sort of using this, using estrogen again, this can be a nice option. Things like minoxidil or 5-alpha reductase inhibitors are often used for androgenic hair loss, just as we'd see used in cisgender men. So testosterone can lead to androgenic hair loss, and these medications can be helpful. Oftentimes these aren't started kind of prophylactically when someone starts testosterone, but rather held and used, only if someone starts to experience hair loss. 5-alpha reductase inhibitors, as you know, will not block testosterone, but really block the conversion of testosterone to the stronger version of what's called DHT, which is typically what causes hair loss. DHT is also thought to help cause beard growth and even bottom growth, so growth of the clitoris, which some people want, right? They find that affirming. So again, usually waiting to start these medications until hair loss is experienced, which is usually years down the road when beard growth and bottom growth has already happened. Progesterones can be nice options for a couple of different reasons, right? So progesterones are, in the form of long-acting reversible contraceptives or LARCs, can be used for birth control and similar. Testosterone, even if someone stops getting a period, is not necessarily, they're not necessarily not ovulating, and so it's not a birth control. So if someone has the ability to get pregnant and is having sex with sperm involved, you definitely want to think about birth control. But there are also, some folks may continue to bleed despite being on T, and they may find that dysphoric. So progesterone can help decrease some of that bleeding. And there may also be folks who, don't think that testosterone would affirm their gender, right? They don't necessarily want deepening of voice or beard growth or anything like that, but are quite dysphoric around their period. And so starting on a progesterone alone may help decrease their bleeding or even stop their period without having to go on testosterone. And then finally, you may have had people ask about testosterone cream or DHT cream for clitoral enlargement. DHT cream, as you likely know, is not FDA approved in the US, and actually we can't get it. So I, just remind patients about that. But I get that question a lot, so I put it in here. Testosterone cream in the genital area, there's really no known benefit of putting the cream directly on the genitals versus just systemic absorption if we use any of the other formulations I've already mentioned, right? So I make that very clear to my patients that just putting the testosterone on the genitals doesn't mean that's going to cause increased growth, right? It's really the systemic absorption. That said, after that conversation, sometimes I have patients who still very much want to put testosterone on their genitals, really feeling dysphoric in that area. If that is true, I make sure folks don't use the commercial transdermal testosterone products, because those are compounded in an alcohol base. So you don't want to put that in the genital area. So usually if folks are going to use the testosterone in the genital area, I do try to get it compounded into a cream or petrolatum base. And usually I've talked to some pharmacies who do this compounding. You may have heard of this, but rather than a pump, which dispenses more medicine, it's a click system. So it's a very small amount, which makes sense sort of if you're putting it in the genital area. So you can do sort of a higher concentration with a smaller click system. So just being aware of that might be something someone asked about. You really want to caution people in using, again, those alcohol-based testosterone products in the genital area, but really think about compounding. If patients really feel strongly they want to do that. So what are some of the effects of testosterone? I think I've mentioned this in my conversation, but just specifically, with someone starting on testosterone, it's not uncommon to have some skin changes. So increased oiliness of the skin, maybe some acne, fat redistribution. Usually this happens more over time after a couple of years being on testosterone. So less taking kind of migration of fat more from the hips and buttocks kind of into the belly area. Cessation of menses, that typically happens sort of early on, depending on, for most people. Some people do get persistent bleeding, but it also is sometimes telltale if someone's on enough testosterone to get their bleeding to stop. So if someone's persistently bleeding, checking their levels might be good. Clitoral enlargement tends to happen, increased libido, vaginal atrophy, as I mentioned. Emotional changes can happen, anytime hormone changes and fluctuations in people's body that can cause emotional changes. I would say for the most part, people feel so much better. They feel calmer in their body. They feel more themselves. But I like to just make sure I normalize that, if you do have some emotional changes or teariness, that's all normal. This is a big process. It's not even just the hormones, but we don't do this in a vacuum, right? That there's also the social aspect. And so always bringing that up, I think, can be really helpful. The clitoral enlargement has the red asterisk, as these are things that tend to be permanent changes, where some of these others, if someone were to stop testosterone, these are non-permanent changes, right? And I do, I give the heads up. I mentioned increased sex drive, clitoral enlargement, some sensitivity in that area, just to make sure folks know that is known to happen, and they're okay with that. Things like deepening of voice, facial and body hair growth, scalp hair loss. Again, these things that can be permanent changes over time. Increased muscle mass, particularly in the upper body. Coarser skin, increased sweating. I've had people talk about, they can't tolerate heat anymore, sort of temperature changes. And some folks experience weight gain, some increased appetite. But again, you're also getting a bulking up some of the muscles. And then just some things to consider in testosterone, with folks on testosterone therapy, especially over time. We think about cardiovascular risk, really interesting in the literature we have so far, which has done actually pretty decent literature. I'm not going to get into all of the studies, but I love thinking about that. Just in the past 10 years, the amount of peer-reviewed papers and sort of medical information we have with hormone therapy is astonishing and really important. So, many of these studies are done in Europe with larger cohorts, often done in Holland or Belgium, but we do have studies in the United States as well. There was a major Kaiser study that came out in 2015. That was a really important cardiovascular study. And anyway, altogether, just to summarize, interesting, there's no increased risk of cardiovascular events that are seen in folks on testosterone when compared to cisgender men. So that's really important, right? We do see changes in lipid profile, so more to what we see in cisgender men, so a lower HDL, higher LDL. We also know, just due to, sort of marginalized populations, social determinants of health, that these populations tend to transmasculine folks tend to have higher rates of smoking and more obesity. And so we do want to think about, again, beauty of doing this work in primary care for me, that I think about preventive health, right? I want to think about what are the modifiable risk factors to make sure that these cardiovascular risks stay on the lower side. But testosterone alone doesn't tend to increase cardiovascular risk. We think about fertility, and I mentioned this a little bit before, that testosterone is not a birth control. We also talk out of two sides of our mouth, where we also say, but if you're on testosterone, you may also lose your ability to get pregnant, or you may lose your fertility. You know, we're gathering more and more information again over the years, and we've actually seen that our reproductive system, for better or worse, is pretty persistent, that there's lots of information, and we have studies of folks who have been on hormones even up through 10 years, who have gone off their testosterone, started menstruating within about 6 months, and able to get pregnant or freeze their egg, have their eggs frozen, so very successfully. So, you know, it's always a good conversation to have before starting on testosterone therapy. Folks don't always know their reproductive plans, and so whether or not someone does that prior to starting, they're good conversations to kind of have along the way. Testosterone does tend to be bone protective. So testosterone aromatizes to estrogen. Estrogen we know to be bone protective. And so, you know, and also we're getting increased muscle mass, so mechanical loading on the bone, so bone protective. Mental health, I mentioned, most people feel much better on testosterone therapy or on hormone therapy that affirms who they are, their authentic self. They feel good. Again, this doesn't always happen in a vacuum, though. We live in a world with, as you know, lots of policies and not always a welcoming spaces. And so we always want to check in on supports and see how people are doing. And, you know, again, from a primary care lens, I always ask about sexual health. Again, we have increased libido, people feeling more comfortable in their bodies. I want to make sure people are finding their pleasures and thinking about risks as they move forward. All right, and I know I'm going through things quickly, but I want to talk about estrogen therapy now. So we're talking about folks who are assigned male at birth and affirming a female or feminine identity. So we're going to talk about estrogen first. So estrogen is sort of the hormone that can cause some physical changes, more in line with what we see for cisgender women. I'm also going to talk a little bit about what's called anti-androgen therapy. So just like testosterone, you know, folks who take testosterone, estrogen, when you take it, is going to suppress endogenous or the body's production of testosterone, right? But as I mentioned before, testosterone is a really strong hormone. So though estrogen will suppress some of the testosterone, it might not suppress enough to feel affirming. So that's why in this case, we also add an anti-androgen. So estrogens, there's lots of formulations. In this case, I say I probably prescribe oral estrogens more so than I do other formulations. Again, it's cheap and it works pretty well. We use the type of estrogen called 17-beta estradiol, which is the it's the bioidentical form of estrogen, so thought to be the safest form of estrogen, and that's opposed to Premarin or the conjugated equine estrogens, which were more popular about 15-20 years ago, or even ethinyl estradiol, which is the type of estrogen found in birth control. Both of these found to be more thrombogenic than 17-beta estradiol. So we stick with the 17-beta estradiol. Usually dosed anywhere from 2 to 8 milligrams per day. Usually divided into twice daily dosing. Though those folks could take it once a day. You may have also heard the debate: do I swallow this or do I use it sublingually? And is one better than the other? And this is, I don't think I'm going to solve this debate today, but I can give you a little information in terms of how to talk to patients about that. So the medication itself is not formulated for sublingual dosing. It's formulated for oral dosing. So even if folks take it sublingually, they're probably swallowing some of it. So we really don't know how safe it is. But the idea is that if you take it sublingually, it bypasses that first pass metabolism through the liver. So it's sort of a parenteral formulation when you take it that way. And so may decrease risk of sort of increasing those clotting factors or inflammatory factors in the liver, and maybe less thrombogenic if taken sublingually. So there were pharmacokinetic studies looking at oral versus sublingual dosing. And essentially what they found is that with sublingual dosing, you're actually getting a pretty big spike in serum estradiol levels within the first 2 to 4 hours of taking it, and then sort of evens off throughout the rest of the day. Whereas if you take it orally, that kind of peak comes a little bit later. So about 4 to 6 hours later, sort of a lower peak and longer peak. Okay, so the pharmacokinetics are much different. And they also found that if you take it sublingually, you get almost 2-fold higher serum levels of estradiol. So patients and even some providers might be like, fantastic, don't we want more estrogen? So definitely taking it sublingually is better. But, again, we also want to think about safety, right? More is not always better. Those high peaks of estrogen may potentially cause increased risks of clotting or may cause, headaches or migraines, right? So we want to think about what are the side effects of having super high levels. And really the goal is to get the serum estradiol levels into kind of that average cisgender female range, which we usually say around 100 to 200. And so if that estrogen is spiking, or if you have double the amount, more is not always better. Okay. So, I think these are some of the conversations I have with my patients, that you can take it sublingually, but we really want to measure those levels and make sure that you're not super therapeutic on your estradiol levels, or you can just as easily swallow them. It's easier, it's down, again, we can check your levels and make sure it's okay, but we're not really sure that, taking it sublingually is reducing any particular risk. There's also injectable estrogens, so estradiol valerate and cypionate. Valerate is a little bit more common. I think it's more readily available. A little bit goes a long way with these medications. I find that dosing anywhere between 5 to 10 milligrams every 2 weeks is usually enough to get folks into that goal range. Some folks do prefer to dose weekly, sort of in that same deal that the peak and trough is a little bit narrower. Although I find with estrogen, the levels, if it's really formulated for every 2-week dosing. And so if you dose weekly, I find the levels sort of, kind of gain on each other. So you really want to monitor that closely. So I really try to, have folks use it every 2 weeks. As you all, I'm sure, are very aware of, is that every year or every couple years, there's a back order of estradiol valerate, and that can be extremely distressing to patients when they don't have access to their medications. So at this point, anytime I start someone on injectable estrogen, I actually have that conversation that at some point, this medication is not going to be available. And if that happens, we'll switch you to another formulation. But I think having that, setting those expectations ahead of time is really important. So I do have that conversation. There's estradiol cypionate, which sometimes is available if valerate goes on back order and is not. The only difference is you want to adjust the dose. It's usually 1/3 to 1/4 of the dose of the estradiol valerate. Pharmacokinetically, there's a little bit, the peak again is a little bit later and not as high of a peak. So though the area under the curve, the amount of estrogen someone's getting is the same, it might just feel a little bit different. So again, I talk about that. But estradiol valerate is usually what I prescribe here. And then there's transdermal estrogens, and these also come in the form of patches and gels. There's several different types of patches. Depending on the brand, they're dosed either weekly or twice weekly. They come in pretty small doses, I think as low as 0.0125, and the highest dose is 0.1 milligram. Folks can do one patch one patch twice a week. I find, especially with my young folks, they usually need 2 patches at a time, 2 patches every 2 weeks to sort of get up into that cisgender female range. And most people actually tolerate the patches well, unlike the testosterone patches, which cause that skin reaction. I find that most folks actually tolerate the transdermal patches pretty decently. If they don't, the estradiol gel is a great option. I don't always jump right to gel just because it tends to be more expensive. But the gel is a cool option if someone can't tolerate the adhesive. Also really nice if someone doesn't feel safe or comfortable having the patch on their skin, if someone would notice the patch, or if they're going swimming or out at the beach. Sometimes the gel, it's you don't see it, right? It's invisible. So that can be a really nice option for folks who have like safety concerns in that regard. So anti-androgens in the United, so again, these are medications used in combination with estrogen to help kind of suppress that sort of extra testosterone that's not fully suppressed, really kind of getting that down into the cisgender female range, which is typically under 55 nanograms per deciliter. So spironolactone is one of the most common anti-androgens used in the United States. So this is a potassium-sparing diuretic. but actually use higher doses, and it acts as an androgen receptor agonist. So this is typically divided into twice daily dosing, usually 50 to 100 milligrams twice a day. Most people tolerate it really well, although it is a diuretic, can interact with other medications. So there are other options if folks feel like they can't tolerate this. One, you can just be on estrogen alone and don't have to be on another anti-androgen. Some people prefer that. Other options are, again, this idea, these 5-alpha reductase inhibitors. So again, these don't inhibit testosterone. The testosterone levels won't change, but what they do is they inhibit the conversion of testosterone to DHT. So I find that these are not as great as spironolactone and kind of helping that sort of feminine, sort of folks feel, these feminine qualities, but it can help with, hair loss if someone still has testosterone around and they're still experiencing hair loss, which can be very dysphoric. 5-alpha reductase inhibitors can be really helpful for that, or even to limit some like beard growth or body hair growth for folks. Progesterones can be good medications. Which I'll talk about a little bit more. They suppress at the central kind of hypothalamic pituitary gonadal axis, and they can block testosterone to some degree. So these can be used. These are often welcome. They're part of a cisgender female makeup, so they're often welcome. And then there's GnRH agonists, right? So again, these work centrally on the pituitary gland, stopping the release of LH and FSH, right? These are very, very extremely effective. The main problem with these is they're really expensive. These are the medications used in puberty blocking for adolescents, but for adults, they're really effective as well. And more in Massachusetts, they're covered for adults. So really cool options if spironolactone is not covered. I did mention, just kind of in the gray here, medication called bicalutamide. This has come up a little bit more, I know, in conversations I've had with folks around the country. It's a non-steroidal androgen receptor inhibitor. So essentially, this is a competitive inhibitor at the androgen receptor. This is actually used in the treatment of prostate cancer. That's what it's FDA approved for, but it's quite effective in decreasing testosterone. It's expensive, and it has the potential of causing hepatotoxicity, rarely, but even to the point of fulminant hepatitis, which can cause death. So right now, more studies are needed on the safety of this to be as part of gender affirming care treatment, but at this point, not really recommended. But that said, a lot of people are still prescribing it, so you may see it come across. Cyproterone acetate is a medication widely used pretty much everywhere outside of the United States for androgen suppression. It's a synthetic progesterone. So you may see this in the medical literature. So just to let you know, this is not FDA approved in the US. So folks who move here from out of the country usually switch to one of these other options. But just so you're aware of kind of where that medication comes from. I'll talk a little bit about progesterones, sort of another ongoing debate in the field, which I love these things. What is the role of progesterone in gender affirming care? Lots of patients actually ask for progesterone as it benefits breast development, or they've heard it benefits breast development. And also, as I mentioned, it's part of the physiologic cisgender female hormone makeup. And, trans or non-binary feminine folks may want this as part of their hormone makeup as well. So we think about, what are some of the risks? We've all heard of the Women's Health Initiative and showing that estrogen and progesterone used together may increase cardiovascular events and breast cancer risk. But again, hopefully we've also seen kind of the studies and the kind of review of that since, right? And we can't necessarily extrapolate all that data onto our trans and gender diverse folks, right? Most of our folks are younger when they start on hormone therapy, and the Women's Health Initiative, the vast majority, I think the average age was 63, right? So our folks tend to be younger. And in the Women's Health Initiative, they were using Premarin and medroxyprogesterone. So two types of hormones two synthetic hormones that tend to be more thrombogenic. And again, we're using ethinyl estradiol, and I'll talk about sort of the bioidentical progesterone that we'd want to use. So though there might be some risk, especially as folks are getting older and our younger folks and with sort of safer medications, these risks may not necessarily apply. That said, progesterone may cause some weight gain, fatigue, depression, or all potential side effects. No, and there's also no clear evidence it can affect breast growth, right? Why be on a medication if we don't know it'll be effective, right? But there are some potential benefits, right? Progesterone can cause weight gain, which for some people can be really affirming, right? It kind of rounds out some curves. Actually, probably it's the weight gain that causes the breast growth and breast development, which is really affirming for folks. So that actually might be a good thing. Anecdotally, I've also heard, and in the literature, people report that though depression is a potential side effect of progesterone, most people are reporting improved mood, improved libido and energy. And as I said, it has an anti-androgen effect. There was one paper, a clinical review about 11 different studies, just under 1,000 patients, looking at what is the direct impact of progesterone on breast development. None of the studies were all that great. Only 3 of them had over 100 subjects in them. And essentially what they found is actually measuring breast growth is very, very hard to do. And so the conclusion was a little bit blah in that, there was no evidence that progesterones enhanced breast development, but nor could they prove that progesterone didn't enhance breast development. So not a very satisfying conclusion. But the one thing, that I pulled from this paper is that of the 1,000 patients, there was no significant risk factors or adverse events that were reported. And so, I think the more and more we kind of think about these things and we think about safety and benefit, I find that this is helpful and reassuring. So essentially, if I'm going to prescribe progesterone, I'm going to prescribe prometrium, which again is the bioidentical formulation. I usually prescribe it at a low dose, so 100 milligrams once a day. And I consider it a trial. And this is in line with the Standards of Care 8, again, that was just published this past fall. Really that, this is a discussion of risks and benefits. So we're back to that informed consent, right? Always going through that. It's a collaborative decision to trial progesterone therapy and see how it goes, right? Just like anything, you don't want to be on a medication that either doesn't do anything or one that causes side effects. So if either of those things happen, we could think about discontinuing. If it's beneficial, we'll continue on for, a certain period of time. And then, at certain points, continue stopping, not unlike a lot of other medications we use. So that's really the approach to progesterone. So some of the effects we're getting close to time, right, David? All right, I got that in mind. So I'll just run through pretty quickly some of the effects of estrogens and anti-androgens. So if someone's androgens or testosterone is suppressed, we may see decreased libido, decreased testicular volume, sperm production. With estrogen, increased breast growth and even breast tenderness. So I like to make sure people know that that's normalizing, to normalize that. We also see decrease in muscle mass, softening of skin. Oftentimes we don't see hair regrowth or voice changes, right? Once the vocal cords are thickened with testosterone initially during puberty, we don't see that thinning back out. I'll quickly go through just sort of cardiovascular risk. Cardiovascular risk, we do actually see a slight increased risk, or we do see an increased risk of stroke or slight increased risk of stroke. We do see an increased risk of venous thromboembolic events. Estrogen does seem to be bone protective, and very similar things that I said about fertility, mental health, and sexual health. I do want to just stick with that venous thromboembolic events, which is higher with estrogen, just to say, and to plug, transdermal estrogens are seen to be the safest formulation of estrogen. So for folks who are at higher risk of venous thromboembolic events or older age, usually as they approach kind of over the age of 40, but definitely into 50, thinking about switching folks to transdermal estrogen really has a similar kind of risk factor as we see in cisgender women with ovaries, right? As opposed to oral estrogen, where the risk can be 4 times higher in terms of venous thromboembolic events. So, I'm going to skip over kind of the rest of this, but really just to say at the end, right, that, I love the idea of an integrated approach to gender affirming care. Like we can all do this work and we should all be doing this work, right? Gender is a part of all of us. And if we can create an environment where people can come in and talk about their authentic self, ask questions about their medication in a way that's affirming, it really impacts not only access to care, but holistic care, where people might also feel more comfortable and feel welcome to talk about all of these other things that are important in terms of preventive health and chronic disease management. So I implore you all to continue this work, and thank you so much for having me.
Thank you, Julie. That was fantastic. We do have a few questions. I don't know if you can see them. One of the first ones asked early in your presentation was, how do you address using medication off-label? Do you envision health insurance companies covering off-label use for gender affirming care?
Yeah, it's unfortunate and it's frustrating at this point that it's still all of these medications are off label, right? And it's not, I mean, I should say also we use medications off label all the time for all sorts of things, right? I think it would feel it would just be more validating if I think if there was FDA approval for these medications for this purpose. We have a lot of information and data at this point, and it would help with things like prior authorizations and cost and policy even, right, in terms of validating the need for this. But I would say it's not unlike any other medication that we use off label, and we have a lot of data to support its use.
Great. Another question was, any limitations in starting hormone therapy within the adolescent population for providers to consider? Any age-related limitations to consider? Thank you.
Yeah, I mean, that's sort of a big question, but typically we think about ages and stages, right? We wouldn't start hormone therapy until it's appropriate age based on someone's peers, right? Even though someone's identifying as trans as young as 6 or 7, the puberty hasn't started at that time. So we only even think about puberty blockers until someone hits Tanner stage 2. And, we won't even think about puberty blockers until that happens. And we certainly wouldn't even think about hormones at that time. We're just thinking about puberty blockers to give a bit of a break, right? And only when it's appropriate in terms of age and again, stage of peers, in terms of hitting puberty, that's when we think about starting hormone therapy if appropriate. And we start low and slow, right? We're really mimicking a puberty. We don't want a 4th grader to come into school with a beard, right? That's not appropriate. We want the kiddo to go through puberty as they would with their peers, again, if that's appropriate. So that's sort of what we think in terms of starting on hormone therapy. So usually you're thinking 13, 14, 15 for testosterone, maybe slightly younger for trans girls, just because puberty starts a little earlier for those kiddos.
Yep. Another question, would you do add-back therapy when using GnRH agonists?
Yeah, definitely. So we always want to think about sex hormones being important for bone health, probably also other things in terms of cardiovascular health and mental health. So, even with puberty blocking or in adults, if you're starting a GnRH agonist and suppressing endogenous sex hormones, you do want to think about adding back, at least eventually or soon thereafter, a sex hormone, again, to protect bone health, libido, mental health, all of that is really important.
Excellent. Maybe time for 1 or 2 more. Tom is cautioning to differentiate between progestins and progesterone. Former is synthetic and has cardiovascular side effects. Natural progesterone does not have this.
Yeah, so in the studies that are done, so prometrium or micronized progesterone tends to have less side effects in terms of cardiovascular risk or even potential for promoting cancer down the road. So that's why we recommend the micronized progesterone over something like medroxyprogesterone. Not to say that I've seen medroxyprogesterone used, but we always want to think about the safest option. Micronized progesterone seems to be that option.
Great. And then I think this will have to be the last question that we can take. It's just about the backlash in other states and policies against gender affirming care. Thoughts on that? I'm sure it makes you feel bad. The question is, how does it make you feel? I'm sure it makes you feel bad.
I have a lot of thoughts on that.
Yes.
Yeah, I mean, it does make me feel bad, but it makes me feel really sad for kids and their families and adults and all trans and gender diverse folks, right? That we know that having these terrible policies affects people emotionally. The fact that their identity is debated in court and by people who are not experts in this field, I think is really dangerous. I think the fact that medicine is being sort of, infiltrated by politics. Again, it's a dangerous place to be in this world, and it does have a negative impact on individuals and on the population, and on us as providers. We're trying to do our work and try to take care of all the people in front of us, regardless of what they come in with. And we're not going to stop doing that work. But it's dangerous to know that this is something, again, that's being debated, and it does have a huge impact. So we want to do what we can in the states where we are, but reach out to other kids, whether or other states rather, and whether it comes to medical policy or kids being able to play sports and have community and be and exercise. I mean, these are all things that are really important to health. So thanks for asking that question. And I have all the thoughts, and I really encourage you all to be involved in that.
Great. Thanks so much, Julie. Fantastic. Well, let me just jump right to Todd Brown. Todd Brown is a pharmacist. He's instructor emeritus at Northeastern University's Bouvé College of Health Sciences, School of Pharmacy. He's also the executive director, as Dennis mentioned, of the Massachusetts Independent Pharmacists Association. And Todd has done this for us before. He's actually he's semi-retired. We pulled him out of semi-retirement to do this for us once again, because it is really vital. I know this is an important update that you guys get, that pharmacists get every year. And it's obviously exceptionally valid, still in the days of a pandemic. So Todd, thanks very much.
Thank you. I'm just going to bring my slides up here.
Perfect.
And let me just bring the chat down. Okay. So hello, everyone. I hope everyone's doing well. And I want to thank Dennis for the kind words at the beginning of this program. So today we're going to talk about changes to the CDC adult immunization schedule. We'll talk a little bit about research on the effectiveness of different vaccinations and identify strategies to increase vaccination rates. If you have questions, please send them to me as we go along, and I'll stop after we talk about each vaccine to address any questions. So before we talk about specific vaccines, it's good to review the ongoing immunization requirements for pharmacists and pharmacy staff to immunize. And so in addition to going through the training program, these things are ongoing. So you have to meet the practice standards by the State Board of Pharmacy or policies and procedures of the organization that employs the immunizer. Federal and now most state guidelines require 2 hours of continuing education each renewal cycle. Some states had to change it to meet the federal guidelines. And so with a 2-year cycle, that's 1 hour each year. So this program will meet that requirement for 2023. And then if you get another hour in 2024, then you'll meet this requirement for ongoing continuing education. You do need a current CPR certificate. And if you look at your CPR certificate, it has a suggested expiration date, not an exact and specific expiration date. And so I've heard from pharmacists, my CPR, it's February 1st and, my CPR expired in January. Can I still immunize? And what I tell them is, yes, you can immunize. You just need to start a process now of getting your renewal for your CPR. So if you're immunizing a month after your CPR certificate expires, that's okay, as long as you have something, a plan in place and can show that you're registered for a program or something like that. If you get beyond 2 to 3 months, then there could be questions, but as long as you try to stay current, if you don't get it done on the exact day or month that it expires, that's okay. And then it's good to remember that there's local record keeping and reporting requirements that I'll go on, that I'll talk about in a minute. So the authorization to immunize previously came from each state, but now also comes from the feds. So the Public Readiness and Emergency Preparedness Act, commonly known as the PrEP Act, authorizes pharmacists to order and administer ACIP recommended vaccines, including COVID, even though that's not on the schedule, to individuals 3 years or older. It also authorizes pharmacy technicians to administer ACIP recommended vaccines to individuals 3 through 18 years and influenza and COVID vaccine to adults under the direct supervision of a pharmacist. And I know the Massachusetts Board of Pharmacy is working on revising the authorization to allow pharmacy technicians to give any ACIP recommended vaccines 3 years and older, so kind of same as pharmacists under the direct supervision of an authorized pharmacist. So the Massachusetts authorization and the policy is listed on the bottom of the slide. You can go to the Board of Pharmacy website and look at that. And as that changes, you'll see a change in that. When you give a vaccination, you should provide a record of immunization to the patient, also to the patient's physician if they have a primary care physician, and it needs to be entered into the Massachusetts Vaccine Registry, the Massachusetts Immunization Information System. And so hopefully everyone has processes in place to make sure that that gets done. Adverse events, if there's an adverse event associated with the vaccine, or even if you don't know if it's associated with the vaccine, you should report it to the VAERS system. And I have the link there. The VAERS system was, in the past couple of years, updated so that it's much easier to report. Previously, you had to download a PDF, handwrite everything in, and then upload it back to the VAERS system. Now they have an online platform that has a writable PDF, so you can fill it in online and then update it right from the website. So it makes it much more easy to provide this information and to report possible adverse events. We know that pharmacies have been involved in immunizations for some time, and COVID has really exacerbated that. And so you can see a chart here from IQVIA, which looked at pharmacy claims, and up until early 2000s, pharmacies and non-pharmacy settings were giving approximately the same amount of vaccinations. Then in the second quarter of 2000, you saw a big dip in pharmacy vaccinations and a big increase in non-pharmacy vaccinations. This was the shutdown during COVID. And so any vaccinations were really being given in health settings. And once pharmacies got COVID vaccine and started immunizing, then we saw a dramatic increase in immunizations in the pharmacy environment. And now we're at the point where about 90% of immunizations are given in the pharmacy as opposed to physician or other healthcare setting. And this chart includes COVID, flu, HPV, pneumococcal shingles, and Tdap. So most of the more common adult vaccines. And so it's good to see that, pharmacies are really doing their part in making sure patients are vaccinated. The adult immunization schedule from the CDC is getting more complex as we get more vaccines. And so they did create an app that can be used to kind of go through the schedule to make sure you're giving the patient the right immunization. Especially the footnotes can be hard to get through because they're so small on the schedule. And so this app makes it a little bit easier to be able to get through to figure out what vaccine a patient is recommended. The link is down below. It's optimized for tablets and smartphones. It is changed every time the CDC changes the immunization schedule, so you don't have to go back and make sure that you have the right schedule. It automatically will be updated. And so I have the link there. If you don't want to use it on a tablet and a smartphone, but want to use it on the web, you can do so. I have a separate link there for the web-based version. So it's a little bit easier to get through that and get the information you need in order to ensure people are getting the right immunizations. ACIP is still using the term shared clinical decision-making for some vaccines in some situations. And these are situations where the broad group might not benefit from a vaccine, but an individual might based upon their individual risk factors and medical history. And so the CDC and ACIP allow providers, including pharmacists, to actually discuss that with the patient and discuss whether they should receive a specific vaccine that might not be beneficial to the broader population. And if the conversation between the healthcare provider and the patient, if that decision is they should receive the vaccine, then it's considered recommended by the ACIP in the schedule, and it should be covered on insurance. We've had some changes in insurance under the Affordable Care Act. Adult patients will now have no cost sharing for ACIP recommended vaccines. That includes those given under shared clinical decision-making recommendations. And in October, adults on Medicaid will also have no cost sharing, as well as children under the Children's Health Insurance Program. So we're getting increased coverage on vaccines, which will make it easier for patients to get them because they won't have to worry if they can afford it or not. This is not new, but because we have more technicians immunizing and greater number of pharmacists immunizing, I always put this in my presentation. We're still seeing an increase in bursitis and shoulder injury attributed to intramuscular injections. So you want to make sure that you get in the deltoid and not into the bursar sac in the shoulder. And so when we teach our pharmacy students how to immunize, we always make sure we point out where the deltoid is and recommend that they're level with the area they're going to immunize. So if the patient's sitting, we have the student pharmacist sit, and so they're at the same level as the deltoid muscle, and they're going in at a 90-degree angle. And that's a little harder if you're not at the same level. So if you're at the same level, it increases the chance you're going in at the right angle and they're not going to hit the bursa sac or shoulder. These are the specific vaccines that we're going to talk about. I picked them because number one, there's changes. Number two, they're the vaccines that pharmacists are more likely to give. And so COVID vaccine, I struggled to include this because we could have talked about COVID for an hour and not even touched all the information. And so I want to start out by saying this is really high level stuff, really basic information. The CDC has a whole page that starts their information on COVID vaccine, and you could literally read all of the links and information they provide for a very long time and not get through it. And so I've provided just the basics here about the COVID vaccine. So we know that the COVID vaccine is based upon age and then also time since the last dose. It's also based upon other conditions. So specifically patients that are moderately or severely immunocompromised. And just to say in general, side effects for the COVID vaccine are common. However, severe allergic reactions are relatively rare. So here we have charts on different recommendations based upon age. The first is 6 through 14 months, where they recommended keeping the same booster as the primary series. And then on the bottom of this slide is people age 5 years. That's when the recommendations change. And now we see that for the Moderna vaccine, the booster can be either Moderna or Pfizer, whereas the Pfizer vaccine, the booster should be Pfizer. And then when we continue, for our people 6 through 11 years old, they can get either the Moderna or the Pfizer, and then either bivalent mRNA booster. For people that 12 years old, we've added the Novavax vaccine, so they can get the Novavax, Pfizer, or Moderna, and then any bivalent booster 2 months later. And then lastly, for people that are 18 years or older who previously got the Janssen vaccine as their primary series, they're recommended to get a bivalent mRNA booster at least 2 months after the primary series. So as far as recommendations based upon clinical conditions, patients that are severely immunocompromised can get an additional primary series dose, and I provide the link here on the CDC that describes all the details about that. So we have the Pfizer and Moderna mRNA vaccines. We have the Novavax, which is a protein subunit vaccine. And then we have the Johnson & Johnson, which is a viral sector vaccine. I'll talk a little bit about all of those. So the mRNA vaccines have mRNA that is designed to produce the spike protein of the COVID-19 virus. And that mRNA is packed into lipid nanoparticles and injected, and that gets the lipid nanoparticles get into the host cell. They release the mRNA, and the mRNA makes the spike protein. It's released into the body, and then we get a general immune reaction from that. And so that's generally how those vaccines work. The Novavax vaccine has copies of the spike protein and lipids to help that spike protein enter the cells, as well as an adjuvant to induce immune response, and salts, sugars, and acids to keep the vaccine stable. The Johnson & Johnson vaccine uses an adenovirus, which is a commonly occurring harmless virus that gets the spiked proteins into the cells. Like the other vaccines, it has lipids to help it into the cells, and salts, sugars, and acids to keep the vaccine stable. And so all of this information, as well as the detailed listing of salts, sugars, acids, and lipids that are in vaccines in case patients have allergic reactions, are available at the CDC website. As far as adverse effects, the most common adverse effects are pain at the injection site, flu-like symptoms. It can cause, like any vaccine, more serious adverse reactions, allergic reactions, and it's contraindicated in individuals with a history of these allergic reactions to the vaccine or any component of the vaccine. Myocarditis and pericarditis have been reported with the mRNA vaccines, as well as the Nova vaccines. And so that's a consideration depending upon the patient being immunized. And then thrombosis and thrombocytopenia syndrome have been reported with the J&J vaccine. And so that right now, the J&J is only used in limited situations because of that. The vaccines come in different strengths based upon age-based dosage recommendations. They also have different storage and handling requirements. And to help differentiate this and prevent errors, the vaccine manufacturers have different color caps and different label border colors for each of the vaccines, and detailed information. I've given you a link here for detailed information. So after each vaccine, I have inserted one question. The question is part of the Immunization Action Coalition, which is a great resource. I recommend anyone that's immunizing to go to that organization and look at their resources. Much of their resources are free. They have lots of flow charts to figure out if someone's eligible for a vaccine, as well as lots of other resources. As I said, most of them are free. Those that cost are very low cost. So it really is a great resource. And one of the sections they have is Ask the Experts. So it allows people to ask vaccine experts, what do I do in this situation? And so, some of the questions really can be answered from the CDC recommendations. So they're really not that helpful, but some of them are very good to, because they clarify something or talk about a situation that could be controversial, or the vaccine provider might not know what to do. So for every vaccine, I've kind of pulled one question just to talk about it. So here for the COVID section, my patient turns 12 years old later this month. Should they get the lower dose vaccine that's approved 11, or get the higher dose at age 12? And the answer is don't wait. Vaccinate someone when they're there to be vaccinated, and try to use the vaccine that's indicated for them based upon their age at that day. But I have also provided the links there. If someone's 11 and almost 12 and they get the 12-year-old dose, that's fine. It's not considered a vaccine error. And vice versa, if they just turned 12 and they get the 11-year-old dose, that's also not a big deal. It's not considered an error. So really, there's more flexibility with vaccines in general. Is when you think about it, what you're doing is you're getting an immune response. It's not like a drug that, very dose specific, and changing this, could cause lots of adverse effects or harm. There's a little bit more variability or leeway in vaccines. So with the COVID vaccine, the short answer is give what they're eligible for at that time. If you realize you've given the wrong dose, don't worry about it. It's fine. Okay, so moving on to influenza. We know that the influenza virus has the hemagglutinin and the neuraminidase portion of the virus, and that the vaccine, the influenza vaccine, has different strains of the influenza virus. Each strain is designated by the virus type, geographic origin, strain number, year of isolation, and virus subtype. And here, this is a chart of influenza illness reported in Massachusetts. And the red line is the 2023 season. And you can see it was very high in December. And during that time, you probably remember news reports about hospitals being very concerned because they had lots of influenza, lots of COVID. COVID was increasing at that time, and lots of young infants with respiratory conditions. And so we thought that it was going to be a really bad season because we were going to get a triple whammy of all these patients with these three conditions getting in the hospital. Luckily, COVID decreased a little bit, influenza decreased a lot, as you can see here, and then the respiratory infections for young children also decreased. So it was a kind of a little blip, but now we're in a much better place than we were previously. You can still see here the for this year, it's a little high, but I think the last version of this chart, which I didn't include here because it was like last week, it continues to dip. So it looks like this year, it's going to be high in the beginning of the year, but also go lower for the rest of the year. So we have a bunch of different types of influenza vaccines. There's the inactivated and the live vaccine. And then under the inactivated, well, all of them are quadrivalent. So that's kind of the biggest difference this year for influenza vaccine is we've transitioned now, no more trivalent vaccines, all are quadrivalent. And the hope is that giving the quadrivalent vaccine with 4 different strains, that's going to make the influenza vaccine more effective. As far as under the quadrivalent inactivated, we have the cell cultured, the recombinant vaccine, the adjuvanted vaccine, and the high dose vaccine. The adjuvanted and the high dose are geared for older patients, whereas the regular inactivated, the cell cultured, and the recombinant are geared to children and adults. And I'll have more information on that in the next slides. So there is a routine recommendation for vaccination of all individuals 6 months of age or older that do not have a contraindication. ACIP does not provide a preference for specific vaccines for individuals less than 65. They refer to the package insert. They do have a recommendation for patients 65 or older that they should receive either the high dose, the recombinant, or the adjuvanted product if available. If not available, then any age-appropriate vaccine can be given, but there is a recommendation to try to give those for patients 65 years or older, because we know they have a decreased immune response, and all of these products are designed to increase the immune response from the immunization. Because of limited data on adjuvants, the CDC says that you might consider a non-adjuvanted influenza vaccine if you're giving another vaccine at the same time with an adjuvant. So we don't really know a lot about giving two adjuvanted vaccines at the same time. They don't recommend it against it, but they do recommend considering giving a non-adjuvanted influenza vaccine if you're giving another vaccine that has an adjuvant. But once again, you shouldn't delay immunization if there's only only the adjuvanted influenza vaccine is available. The CDC does state that October is the best time to vaccinate because the coverage would last through the flu vaccine season, through the flu season. Early vaccination in July or August could be associated with suboptimal coverage at the end of the influenza season, particularly among older adults. But if someone, is going away and they want to get it, before October, that's fine. And then you should continue to immunize until the vaccine is no longer in date, which I believe is usually in June. So here we're in February, you can still give the influenza vaccine to anyone that wants it. Additionally, for pregnant people in the third trimester, they do recommend vaccination in July or August for people that are in the third trimester at this time, because the vaccine might reduce the risk for influenza in infants during the first months of life. If someone is in the second and third trimester, they should vaccinate. Because later on in September, October, it might be not possible. Here's a chart that talks about the dose in children, and it's actually older. The 2020 should be 2021, and the 2021 should be 2022. So this is a year old. I couldn't find the updated chart. But most people get one dose of vaccine, unless it's a child that has not received the vaccine yet, and then they should get 2 doses. So if they've had the 2 doses previously, then they get the 1 dose. If they haven't had the 2 doses previously, or you can't verify that they've had the 2 doses previously, they get 2 doses the first year, 4 weeks apart, and then 1 dose every year after. And for patients that are 8 on their first dose, and then 9 on their second dose, that's fine. They still get the 2 doses because they started when they were age 8. I know that we're now immunizing children more than previously, and some people, when they were trained to immunize, the immunization program might not have gone over this. And so I provided a link from the Immunization Action Coalition on how to immunize children. And actually, this document is actually used for the Massachusetts authorization to immunize for the standing order for children. So the Massachusetts Department of Public Health also recognizes this document as far as basic information on how to immunize. As far as precautions or contraindications to the influenza vaccine, precaution is moderate to severe illness with or without fever, or history of Guillain-Barré syndrome within 6 weeks of the influenza vaccine. And this is not a contraindication, just a precaution. The only contraindication is history of severe allergic reaction, not egg allergy, to any component of the vaccine. So the issue with moderate to severe illness is if someone gets the vaccine and now they get a fever, it might be difficult to determine whether the fever is due to the moderate to severe illness or to the vaccine, and that might cause some problems figuring out how to treat the person. And then the issue with Guillain-Barré syndrome is that there's a slight increase in Guillain-Barré syndrome with the influenza vaccine, and then with people that have had Guillain-Barré syndrome within 6 weeks of the vaccine, there is a chance they could get it again. And so for both of these, really the issue is making sure they have access to appropriate health care after getting the vaccine. So for someone that has had Guillain-Barré syndrome within 6 weeks of the influenza vaccine, and they're telling you they're going off the grid for 2 or 3 months to go camping and will have no access to anything, that might not be the best time to vaccinate someone with the influenza vaccine. But if they're going to be around and they have access to health care and there's no issues with that, then it would be okay to immunize that person, particularly if they want to be immunized in a medical setting. As far as a live vaccine, there are more contraindications because it's a live vaccine. So like the inactivated, history of severe allergic reaction, but then also children that are getting aspirin or salicylate therapy, that's a contraindication. Children who have a diagnosis of asthma in the past 12 months, patients that are immunosuppressed for any cause, including medications or HIV, close contacts or caregivers of severely immunosuppressed, pregnancy. So if someone's pregnant, you want to give the inactivated one, and then history of influenza antiviral medication, which I'll discuss in a minute. So for all of these situations, you want to think about giving the inactivated vaccine as opposed to the live vaccine. The vaccine was reformulated this year, as it is most years, to try to closely match the circulating virus. So we know for both the cell and the recombinant vaccines, there was a new A strain and B strain. The B strain is different based upon whether it's a cell-based vaccine or a recombinant-based vaccine. And that's because the recombinant-based vaccines can be produced more quickly. And so the CDC has more time to figure out what the best strain is versus egg-based vaccines that take longer. And so here is the list of quadrivalent inactivated influenza vaccines that are available and the minimum age of each of these vaccines. So we have a bunch of the standard dose inactivated vaccines. They're all indicated for 6 months or older. Then we have the adjuvanted standard dose vaccine that's indicated for patients 65 years or older. We have the cell cultured vaccine, which is indicated for 6 months or older. Then we have the recombinant vaccine, which is 18 years or older. And then we have the live vaccine, which is indicated for patients between 2 and 49. And then we have the high dose vaccine, which is indicated for patients 65 years or older. There is no latex in any flu vaccine. And thimerosal is present in multi-dose vials of the flu vaccine, but my sense is that most pharmacists give or use the vaccines that are already drawn up in the syringe so that they don't have to worry about drawing vaccines up. And these don't have any thimerosal in them. According to the FDA, cell-based vaccines may be more effective than egg-based vaccines. This is because we can adjust the strain on a more timely basis because they're quicker to produce, but also because cell-based vaccines don't undergo as many mutations as egg-based vaccines. And so we have two of the cell-based vaccines, the Flucevax, which uses mammalian cells, and the flu block that uses insect cells. And so I would predict that we would have more cell-based vaccines as opposed to egg-based influenza vaccines going forward, just because they're easier to make and they can use the time period to produce them is less, and we can get a better strain in there and have them be more effective. But right now, there's no change in the FDA recommendations based upon cell or egg-based vaccines. They're considered at this time the same based upon ACIP, and there's no preference given to one or the other. But if someone can tolerate the cell cultured vaccines, it might be a consideration. They might want that as opposed to the egg-based vaccines. We now know that respiratory infections, including flu and pneumonia, increase the chance of heart attack or stroke. And researchers speculate that the respiratory infections put more stress on the body that can lead to the cardiovascular event in predisposed individuals. So more evidence that we should be immunizing for these patients, so that particularly those that might be predisposed to a cardiovascular event. There is ongoing research on developing better flu vaccines that are more effective. Right now, influenza vaccines are designed to stimulate a response to the hemagglutinin protein of the influenza virus, but researchers have identified 3 monoclonal antibodies that bind to the neuraminidase protein instead of the hemagglutinin protein. And this seems to provide broad protection in mice. And so the thought is that this could lead to a more effective vaccine. Obviously, more research is needed, but this was recently announced and could change the way influenza vaccines are given in the future. As far as talking to patients about the flu vaccine, you can talk about the prevalence and severity, that this year has been a high year for flu vaccine. The optimal time is October, but it can be given anytime. That the flu vaccine has been reformulated, so hopefully that will mean increase in effectiveness. Patients still think that they can get influenza with the vaccine. They can't, and so this is a good talking point. And then during COVID, it's important to be immunized because you don't want to have to go to the hospital with flu when people are there with COVID. There's a couple of resources that I've identified here for you. The CDC has a Fight Flu Toolkit available with the link here, provides lots of resources. And then the Immunization Action Coalition has a flu defense website that's really geared toward talking to older adults about influenza. So I would recommend that you look at those if you're looking for additional resources. We know that there's some drug interactions with the influenza vaccine. The inactivated flu vaccine can be given to patients that are getting antiviral therapy for flu and influenza. However, there is an interaction between the live vaccine and influenza antiviral therapy. And it's based upon the pharmacokinetics of the antiviral drug. So here you see that if patients did receive the live vaccine and then needed antiviral therapy, they should be revaccinated, or if they haven't gotten the vaccine yet, here is the time period that they shouldn't be vaccinated based upon each of the influenza antiviral medications. We know that influenza vaccine and statins have a drug interaction. We know that statins blunt the effectiveness of influenza vaccines. Studies have shown antibody titers 30 to 40% lower, and an increase in respiratory infections in patients during high influenza activity. However, because of the benefit of statins, there is no recommendation to stop the statin while you're giving an influenza vaccine. And so right now there is no change in the recommendation. Patients should know that if they're on a statin, they're going to have a lower response to the influenza vaccine, but there's no change in the recommendation. They should still get it, and there shouldn't be any change in their drug therapy. We also know there's a drug interaction with methotrexate, that may blunt the effectiveness of the influenza vaccine in patients with rheumatoid arthritis. There's a study listed on the bottom where they looked at patients on methotrexate and assigned them to a methotrexate continue or methotrexate hold group. And then they gave the vaccine and measured the antibody titers 4 weeks after. And what they found was the methotrexate hold group had a satisfactory vaccine response versus the methotrexate continue group, which had much less of a response. When they looked at the methotrexate continue group, they found that there was a difference based upon the dose. So for patients that took 7.5 milligrams per week or less, the difference in vaccine response was not significant versus those who took methotrexate 15 milligrams a week or more. So we know that the drug interaction is more pronounced in those patients that are on higher dose. And so the question is, well, do you stop the methotrexate while you're giving the influenza vaccine? 8 patients in the methotrexate continue group and 10 patients, so twice the amount, experienced a rheumatoid arthritis flare 4 weeks after vaccination. So the issue is, do you just deal with the decreased response by the influenza vaccine, or do you hold the methotrexate to get a better response, but then increase the chance of a rheumatoid arthritis flare? And so there is no recommendation from the CDC at this time. If patients want to think about holding their methotrexate, they obviously need to talk to their provider to see if this is appropriate given their medical history. But it would be good to let people know that there is this decrease in response based upon their medication. Okay, so our influenza vaccine question. Can a child 6 months through 8 years of age who needs 2 doses receive different products for the 2 doses? And the answer is yes. The doses may be the same or different products. There is all of the vaccines are considered interchangeable if they're indicated for that age person. So really it doesn't matter what you give for the second dose, can be the same or it can be different. Okay, measles, mumps, and rubella. CDC recommends all children get 2 doses of the MMR vaccine, are starting at age 12 through 15 months, and then 4 to 6 years age. They can get the second dose as early as 28 days. MMR is a little bit different from other childhood vaccines because we don't give it until year 1, and that's because antibodies are transferred from the mother to the child that make getting the vaccine less effective. So we wait a year till the antibodies kind of die down a bit and then give the MMR vaccine. Since 1978, we've had 1 available vaccine from Merck, but in June of last year, the FDA approved a second vaccine called Priorix from GlaxoSmithKline. ACIP considers them fully interchangeable, although they say it's best practice to give the same vaccine for both doses. If it's unavailable or unknown, then you should give whatever's available. And I have the reference down on the bottom of the slide there. We know that previously we had outbreak of measles, but that's been resolved. But we know that patients with measles can remain immunosuppressed for months to years after recovering from a measles infection, leaving them susceptible to other infections. And so you'll see continued efforts to try to get people vaccinated because of the adverse effects seen by measles infection. So The question, I have a patient who claimed to remember receiving the vaccine, but no written record, or patients who have report the patient has been vaccinated. Should I accept this as evidence of vaccination? And their answer is no. You never report self-reporting. If you can't actually document it in their medical record or look it up in the vaccine registry, then you should assume they haven't been vaccinated, and then you should start at the beginning and have them go through a full series of vaccination. And that's the case for most vaccines. In most situations, unless you have solid documentation, they get it. You should assume they haven't been vaccinated. Hepatitis V is recommended for all adults, age 19 to 59. This was changed from only those with increased risk and certain adults 65 years or older who are at greater risk. We now have a new vaccine, Pre-Hevbrio, that was approved in 2022. The number of doses for the vaccine depends upon the product that's used, so it's not necessarily the same and interchangeable in all cases. The Heplisav-B is a 2-dose schedule, whereas all the others are a 3-dose schedule. And the 2-dose schedule for Heplisav is at 0 and 1 month, versus the 3-dose schedule is the first dose, 4 weeks between the first and second dose, 8 weeks between the second and third dose, a minimum, and 16 weeks between the first and third dose. So I know that's a little bit complicated, but it's 4 weeks between the first dose, 8 weeks for the second dose, and 16 weeks between the first and third dose. The reason why Heplisav has a different dosage schedule is it has an adjuvant that allows for increased efficacy with fewer doses. So the 2-dose schedule only applies when both of the doses are Heplisav. So if the second dose is due and the Heplisav isn't available, then you give something else and revert to the 3-dose schedule. If they got the first dose of another vaccine, they can get the 2 doses of Heplisav afterwards if they want to transition to Heplisav. Okay, so the hepatitis B vaccine question: if the vaccine series is interrupted, does that series need to be restarted? And the answer is no, that if it's been interrupted, you just continue when you can. So if the Heplisav B series is interrupted, meaning they got the first dose and not the second dose, give it as soon as possible. If any of the others are interrupted, the second dose should be administered as soon as possible. And the third dose should be given as long as it's 8 weeks between the second and third dose. If only the third dose has been delayed, it can be administered as soon as possible. So that's all kind of consistent with the dose, the series, and the schedule that we just talked about. It's a minimum, it's not a maximum, and so you don't need to restart it. Pneumococcal vaccine, there's been big changes here. Previously, ACIP recommended the use of 23-valent pneumococcal vaccine, known as PPS-23, in adults 65 years or older at increased, and those younger at increased risk. They also recommended the 13-strain vaccine upon shared clinical decision-making. This has been changed now. In 2021, the FDA licensed 2 new vaccines, PCV15, which is a 15-strain vaccine, and the PCV20, which is the 20-strain vaccine. Now the ACIP is recommending PCV15 or PCV20 in 65 years or older, or those younger with certain underlying conditions who have increased risk. If PCV15 is used, they recommend it they recommend a dose of PPSV 23 1 year later. Adults with immunizing compromising condition can get the PPSV 8 weeks later instead of 1 year. Adults who previously received PPSV only can receive the 15 or 20 1 year after the PPSV dose, and adults who previously received PCV 13 should receive the PCV 23 1 year later and are not indicated for any of the new vaccines, the 15 or the 20 strain vaccine. And the Immunization Action Coalition has nice flow charts to kind of work you through this, because I know it gets complex. So the two new vaccines, PCV 13 is Vaxneuvance by Merck. It's supplied in a pre-filled syringe. The dose is 0.5 mL IM. It's stored in the refrigerator and should be protected from light. The PCV 20 is Prevnar 20 by Wyeth. It's supplied in a pre-filled syringe. The dose is also 0.5 mL. It's stored in the fridge. This vaccine is a suspension, so it must be shaken to produce a homogeneous white suspension before it's used. Both products are latex-free. And then just to be complete, we also have the PPSV 23. This it's not new. It's the Pneumovax by Merck, and it's recommended for people that got the PCV 13 vaccine. Contains 11 serotypes, not in the PCV 13 vaccine. So the question, my patient received PCV 13 a year ago and is now due for the PPSV 23, but my clinic only has PCV 20. We do not have PCV 23 in stock. What do I do? And the question is, you can use the PCV 20 if the PPSV 23 vaccine is not available. Moving on, the zoster vaccine, the vaccine that was approved a couple of years ago now is Shingrix. It's a recombinant adjuvanted vaccine, so it's not live like the previous vaccine, the Zostavax. The target group has been changed, adults 18 years or older. And not only is it approved to 18 years or older who have not received the Zostavax, the previous vaccine. If someone got the Zostavax, it's recommended that they get revaccinated with the Shingrix, which is a very rare situation. But this is one of the cases, and that's because of the increased effectiveness of Shingrix. The vaccine efficacy is 98% after 1 year and goes down to 73% after 10 years, but still very effective. And so there's enough benefit for those who were previously vaccinated with Zostavax to now get the Shingrix. We know that patients with type 2 diabetes have an increased risk of having herpes zoster. And we also know if these people get herpes zoster, they have greater complications or more severity in their type 2 diabetes. So I know we're getting low on time, so I'll just let you read that on your own. The vaccine question, can someone who has experienced an episode of shingles be vaccinated with the zoster vaccine? I think someone's asking that in the question, so I'll answer it now. And the question is yes. If they've had herpes zoster infection, they should still get the Shingrix vaccine. It should be delayed until their acute illness is over, but then they should get it. And the reason for that is, although it's not common, you can get herpes zoster more than once. So remember, the herpes zoster is the chickenpox vaccine that's dormant inside your body and gets reactivated. And just because it gets reactivated once doesn't mean it can't get reactivated again. So that's why they recommend the Shingrix for everybody, including those who have had a herpes zoster infection. Yes, Shingrix, there's a question who it's indicated for. Yes, ACIP, 50 years and older, as opposed to the Zostavax, which I believe was 65 years and older. So slightly different group. Tdap, I put this here. So the WHO does not recommend boosters for Tdap. They looked at other countries that didn't and came to the conclusion that it wasn't a benefit. So this is where the CDC and the WHO divert. They are still recommending Tdap boosters every 10 years for adults. And so they recently updated their recommendations that Tdap and TD can be used interchangeably. So if you only have one, you can give it as opposed to stocking both. And in October 22, the FDA approved the use of Boostrix during the 3rd trimester of pregnancy to prevent whooping cough in infants. ACIP has not incorporated this into their recommendations yet, and so pharmacists can't give it because it's not in the CDC adult immunization schedule, but it should be in there soon. Usually within 3 or 6 months after a recommendation, it gets into the adult immunization schedule. The question, what's the difference between the two Tdap products, Boostrix and Adacel? Both contain protection against T, diphtheria, tetanus, and pertussis. Boostrix is licensed for people 10 years or older, Adacel 10 through 64. The vaccines contain different number of pertussis antigen and different concentrations of pertussis antigen and diphtheria toxoid. It's a little bit of a word change there. As far as new research that's being done that we expect to see sometime in the future, there's several companies looking at respiratory syncytial virus vaccine. That's the virus that is an issue with infants, and there's several companies looking at developing a vaccine, and then there's several companies looking at using mRNA technology to produce an influenza vaccine. And so we might see in the future influenza and COVID vaccine in the same vaccine using the mRNA technology. Okay, so I know we're just a tiny bit out of time, but let me just see if anyone has questions.
Yeah, there are quite a few questions in the chat, Todd.
Let's see, ACIP voted an additional update for pneumococcal guidance in a MNR. Yes, so there is a suggestion to give an additional update for, well, I think we talked about the measles, mumps, rubella vaccine and the new vaccine that's available. I think that's what that's about. If patients receive PCV 20 before age 65, or they receive another one at 65. I'm not sure about that off the top of my head. I think it depends on how long before 65, but yeah, I don't know. I don't know the answer to that question off the top of my head. I'm seeing OBG physicians saying to get Tdap, knowing the time interval is less than the 10-year repeat, the 10-year booster. So if physicians are recommending immunizations that deviate from the ACIP recommendations, they can do so, but you can't give it. So you would have to refer those patients back to the physician because your authorization is only to give immunizations based upon the ACIP schedule. So if someone's using it off the schedule, that's not something that you're authorized to give. And then I think someone had questions about travel vaccines.
Yes.
If the travel vaccine is in the adult immunization schedule, you can give it. If they're not, which I think this case, this question is about, if they're not in the schedule, you're not authorized to give it. So you would have to have someone else give that vaccine. Pharmacists and technicians are right now only authorized to give vaccines in the adult immunization schedule, unless you have a collaborative practice agreement with a physician, and that is a whole different way of being able to immunize over and above what is authorized by the feds and Board of Pharmacy. But you would have to go through that process in order to get authorization to do that. I think I got most of the other questions.
There's a question about for those who have conditions for repeat pneumonia shots. It is still given 5 years after last pneumonia shot. Is this repeat cycle? What is? Did you see that one?
No, let me see.
Up at 1028.
For those who have conditions for repeat pneumonia shot, it's still yes. So so the pneumococcal vaccine is given routinely for patients 65 years or older, but those under 65 years that are at increased risk. And so it still, yes, it's 5 years. After 5 years, if they're over 65, then you can give it again if they received it previously before 65. So there's been no change to that schedule.
Great, Todd. I think we probably have to end there. Thank you very much.
Yep.
And if you, so this next panel discussion is a regulatory update from the drug control program. So we have 3 folks who are going to give their various updates. Michelle Chan will go first as the quality assurance pharmacist for the Massachusetts Board of Registration of Pharmacy. And then William Frisch, who is the director of pharmacy compliance with the Mass Board of Registration of Pharmacy. And finally, David Johnson, who is the director of the drug control program at the Mass Department of Public Health. So with that, Michelle can go first.
Great. Good morning, everyone. My name again is Michelle Chan. I'm the quality assurance pharmacist with the board. Bill Frisch is going to be answering questions in the chat. If you have any questions as we go along, you can just put them there and he'll help out with those. So neither of us have any potential or actual conflicts of interest, and we're not going to be discussing any commercial products, whether investigational or not. So our objectives today are to go over the differences between legislation and regulation, determine the process on how to implement a new regulation, as well as go over some new documents and revised documents that affect pharmacy practice. So we have a lot of terms that we kind of toss around. We have legislation, regulations, policies, circular letters, and advisories. We're going to go over each one, how they're implemented, and give examples of each one. So legislation versus regulation. So what's the difference? So legislation is enacted by the legislature. Another name for it is a statute. Statutes, laws, or mass general law in our case. So legislation generally gives a high overview of what the requirement is intended to be that the legislature would like to put into place.
Michelle, can I just interrupt you for a second? We can't see your slides.
Let's see, sorry about that. I apologize for that. Let's try that again.
Much better.
Are you seeing them properly now?
Yep, it's not in, yeah, now it's in full screen.
Okay, great. I apologize for that. So where were we? Okay, so regulations, in Massachusetts case, it's CMR, the Code of Massachusetts Regulations, and the Board of Pharmacy Regulations are actually 247 CMR. So regulations are authorized by the statutes and they have the full effect of law. So this is something that the Board of Pharmacy develops and puts into place. If you think of legislation as the what and the regulation is the how-to, that'll help you differentiate between the two. So one very important difference between legislation and regulation is that legislation cannot be waived. It's enacted by the legislature. The board has no input to that, so the board has no authority to waive it. Whereas in a regulation, there is potential for the board to grant a waiver. So for instance, if you think of continuing education requirements, legislation in law, it says that pharmacists have to have 20 CE credits every calendar year. And if you engage in or oversee sterile or complex non-sterile compounding, you have to do additional CEs there as well. That's in legislation, and the board cannot grant waivers for those. Regulations, however, pick up and give a little more detail as to what the CE requirements will be. So there's the maximum of 8 credits a day, the requirement for 2 law CEs, and the requirement for live CEs. Just as an aside, the law CEs do not have to be live. So how is a regulation promulgated? Well, after a law is passed, then it falls to the board to develop the draft regulations. So we tend to develop those with interest holder input as well as expert input. And then they will go in front of the board for the board to review and edit as appropriate. After the board reviews that first draft, it will go out for a public comment. Anybody can make public comment. Any licensees or non-licensees are welcome to make public comment. The public comment period usually lasts about a week, but there is an in-person, generally for a couple hours, there's an in-person time during that week, though they do encourage you to do the input in writing so that there are no mistakes in interpretation of what you'd like to say. After the public comment period is over, the legal team collates all the comments and puts them into a nice little grid for the board to review and decide which comments they would like to incorporate into the draft and which ones they would not like to. After they make those changes, the final draft is approved by the board. And once that's approved by the board, it will go up to the state executive offices for their review so that they can make sure that the regulations don't bump up against any of the other laws or regulations. And then after that review is completed, we'll get authority to publish and implement the regulation, excuse me. So this next set of documents that we have are called advisories. And advisories are intended just to give some advice. They are generally not binding, not enforceable. They generally tend to provide best practice information as well as helpful tips on how to meet a certain requirement that the statute has. So the first advisory I'd like to go over is the one about non-sterile compounding. So as many of you probably know, this past fall, USP removed all the levels of non-sterile compounding. So there are no more simple, moderate, and complex levels. However, Massachusetts law will continue to recognize complex non-sterile level of compounding. It also requires us to develop a special category of licensure for pharmacies who will be conducting that sort of compounding as well. Simple, some factoids about non-sterile compounding. Simple reconstitution is not considered compounding. So reconstituting amoxicillin, cephalexin, or anything like that, that generally happens in a typical retail pharmacy, that's not considered compounding at all. Breaking and splitting tablets that are not hazardous drugs, that's not compounding either. Pre-measured kits, however, are compounding, and usually it'll say compounding kit on the outside of the box. So that's a clue that it is compounding for that particular product. Other requirements are to have that the product is a non-sterile compound on the label, and that's so that the end user knows that it's a compounded preparation and not something that's FDA approved, commercially available product. Reconstitution should be documented somewhere, so just so that there's a record of it. Flavorings have to be documented. That's a requirement now with USP that you actually have to document addition of flavoring. So what exactly is complex non-sterile compounding? So it'll include dosage forms like lollipops, suppositories. They require special equipment and special training to create the product. So that's how they fall into these categories. So that does also include HD drugs, hazardous drugs, since that does require special procedures and special training in handling those. So this this advisory does list a lot of examples on it if you'd like to hit it later on. The board also has a bunch of sterile compounding advisories. We have ones about above action level monitoring in an ISO classified space, things to consider when you're remediating it, things you may not have thought about, just a list of stuff that will help you out. How to use smoke studies to determine airflow in your ISO classified areas, and what to do with a failed HEPA filter or HVAC excursions. We also have one on media fills and how best to use those and to perform them. If you go to the board's website, there's a section under pharmacy practice documents that actually is listed as compounding, and all the compounding documents are in one spot for ease of use. The next group of documents are policies, and policies are considered sub-regulatory guidance, so they are enforceable. They tend to give more details than the law or the regulation can have in it, and it allows us to update it as things change. So the first policy I'd like to talk about is one about continuing education. And this is one that we always try to keep updated. It tends to cover everything. So it's got information about new pharmacists, newly transferred pharmacists to the state, CDTM pharmacists, and compounding pharmacists. It kind of is hopefully one-stop shopping for all CE requirements. So the acceptable CE types are ACPE and ICPE. ACPE obviously are the pharmacy credits. ICPE are interprofessional continuing education credits. And that group, of which ACPE is a founding member, they issue credit for more than one healthcare discipline. So it could be one ICPE number for both pharmacists and nurses for a particular program. AMAPRA Category 1 is physician credits, just so that you know Category 1 counts, but not Category 2. And then if there are any programs out there that are approved by United States Board of Pharmacy, those would be acceptable as well. I'm not sure if any other states are still doing that, but if they are, they would be accepted here in Massachusetts. Annual requirements, maximum 8 hours a day, 5 live, 2 pharmacy law. The 2 law do not have to be live. So as I mentioned earlier, between legislation and regulation, where we have legislation that has the high overarching requirement for 20 CEs and the compounding CEs, and then the regulation, which gives some more detail. Well, this policy gives even more detail that might not be, we might not be able to put into regulation. So what duties require those special credit hours? So the statute says for pharmacists who engage in or oversee compounding. So this one will actually tell you that if you are physically compounding, or if you're checking a compound, then you need the credits. It used to be that you would need the credits if you were verifying an order that would have to be compounded by someone else, but that's no longer the case. This policy also defines what a compounding credit is. ACPE has a compounding code, but it's non-specific to sterile or non-sterile. So the title of the program would have to say something like sterile or non-sterile for it to count for one or the other. USP 800 would not count for either if it doesn't say either in the title. USP 800 is more than just compounding. It's about hazardous drug handling. And so just be aware of that. Scope of practice of pharmacy technicians and pharmacists and interns. So we have 2 classes of technician licenses. So there's a pharmacy technician in training and then a pharmacy technician. A pharmacy technician could also have a national certification, but there are still only 2 classes of licenses that we have here. So except for trainee, technicians can request and accept verbal scripts as long as there are no changes. A certified technician can actually accept new prescriptions and as well as transfer C6. Technicians can perform remote data entry, but only a certified technician can count or handle C2 drugs, which means basically stocking an ADD or physically counting out for a prescription. As Todd had mentioned earlier, currently the PrEP Act only allows certain technicians to give immunizations on the ACIP list up to the age of 18. As of last Friday, a new regulation was updated, that is 105 CMR 700. So technicians can now administer vaccines for ages 5 and older. So there's no more limit of 18. Just so that you're aware of that. Pharmacists and interns can administer certain injections, and those injections are listed specifically in certain policies and circular letters. So pharmacists can give substance use disorder drugs and behavioral health drugs, but there is a list of those drugs that you can give. You can't give everything. Pharmacists can administer vaccines that are on the ACIP list, as well as COVID vaccine, but they cannot give penicillin skin tests or any other medication that's not authorized by regulation or a policy. Pharmacists can give health promotion screening tests and COVID-19 tests. They cannot diagnose, but they can certainly make recommendations for symptom management for a patient who's having an issue. So the Board of Pharmacy has a sister program called the Drug Control Program, and the director of the Drug Control Program will actually be speaking after me, but just so that you know, they're our sister agency. They do things like handle the PMP program, they license manufacturers and wholesalers, and they also administer the regulations for how a prescription needs to be written, the prescription format. So what they have is a circular letter, and that's equivalent basically to the board's policy. So these also are enforceable documents. So during COVID, certain nurse practitioners were given the authority to prescribe and not have to have a supervisor at all. So that made it a little difficult because there is a regulation saying they have to have their supervisor's name on the prescription. Some nurse practitioners can practice without having a supervisor and some cannot. So instead of the pharmacy having to figure out who needs it and who doesn't, you can simply fill a prescription that doesn't have a supervisor's name on it. So if the nurse practitioner has to have their supervisor's name on the script, then it's their responsibility to put it on there, but it's not the pharmacy's responsibility to have to check it. So you can simply fill it without the supervisor's name on it. Schedule 2 prescriptions, it used to be that Schedule 2 prescriptions from out of state had to be written by a physician. Now you can accept those prescriptions from any authorized non-resident practitioner. So you can now take a prescription from a dentist for a C2 from out of state, or a nurse practitioner or a physician assistant. All of those you can now accept in Massachusetts. It doesn't have to be a physician anymore. However, there have not been any other changes to Schedule 2 validity for out-of-state scripts. They're still only good for 5 days, and you can still only take C2 narcotics from a contiguous state or lane. Luckily, we're able to accept the stimulant C2 prescriptions from any state. Since we have a lot of colleges here in the area, students are able to access their medications here. Here's the information for Dave Johnson, the Director of Drug Control Program. He'll be speaking again. Like I said, he'll be speaking after me, so you can feel free to reach out to him with questions about circular letters. I know what was mentioned earlier about the access law. The access law is to provide greater access to birth control and emergency contraception. So it used to be that if a pharmacist wanted to dispense emergency contraception, they had to have specialized training, and they had to get a standing order from a prescriber. Now there's a statewide standing order. The pharmacists no longer need training. The standing order also includes antiemetics for any patients that may want one. And it's not supposed to have a cost, but this is not all insurers. So if a patient wants to get emergency contraception under the statewide standing order, just verify with the insurer that it's going to be covered. Birth control also, a patient can come in and get 12-month supply of birth control after a 3-month trial period. But again, it's not all brands of birth control, and it's not all insurers. So if a patient wants a 12-month supply, just check in with their insurer to verify that that particular product is covered. If you get a prescription for a 3-month supply with 3 refills and the patient wants all 12 at once, that is something you can do. You can change that quantity to a 12-month supply with no refills. Generally, those supply limits for Schedule 6 are driven by insurance, not by regulation. So you can feel free to change that. And we do have a policy on changing prescriptions as well on our website. So as the investigators are out inspecting pharmacies, they come across a lot of non-compliant things. So we'll just go over a few of those things so you can see what's out there. So this is a COVID vaccine that is located near some dusty electrical cords and food. And there is a needle in it that the pharmacist wanted to draw the doses off the needle rather than puncturing the vial too many times. Unfortunately, now that the needle is in there, it's exposing the contents to ambient air, and that product is no longer sterile. The balance on the left there is not sealed as required by board regulations. But the bigger problem here is that broken granulated cylinder on the right. And the biggest problem with that was that it was still being used. Just going to go through a few questions here. I'm not going to, do a poll question or anything, but we can just give you a few minutes to read the question and answer it in your head. So which is true regarding legislation? It may be waived by the board. It provides an overarching mandate issued by the board, or none of the above. So I'll just give you a second or two to think about it. So legislation provides an overarching mandate. It provides a high level description of what the requirement is to be. The board does not put it into place. That's done by the legislature. They don't write it and they can't waive it. So which CE types count for pharmacist credit? So is it AMA PRA category 1, ACPE, ICPE, veterinary CE, CEs approved by a board of pharmacy, or Canadian CEs? So there's more than one correct answer here. So category 1s are the physician credits that can be accepted. Again, category 2 do not count. And US Board of Pharmacy CEs would count from anywhere in the United States. I didn't go over e-prescribing, but because I think Dave will be going over it a little later on, but I did want to leave this question in here to talk about e-prescribing. So e-prescribing is mandatory. What do you do if you get a handwritten prescription? Do you only fill it if it's a C6? Do you have to contact the prescriber to see if they have a waiver, or can you just fill it? So if you get a prescription that's handwritten or verbal or anything, you can go ahead and fill it as long as it's otherwise valid and appropriate. You can fill it for any schedule of drug. There's no need to contact the prescriber to see if there's a waiver. And this was done deliberately to make sure that patients aren't caught in the middle and there's no delay of drug therapy on their part. E-prescribing is mandatory. E-prescribing is different than filling a prescription. So it's mandated for the prescriber to prescribe, but not for you to fill. The board has a pharmacy substance use disorder program. It's a confidential 5-year recovery program for pharmacy licensees who are suffering from a substance use disorder involving alcohol or drugs. If you have any questions about this program, you can reach out to Ed Taglieri at his email address or phone number. But please do not email any personal information because state email is considered public record. The board does have a website, and we are in the process of rehabbing it a bit. So if you go to our homepage, you'll be able to find pretty much everything here. So the board moved location a couple of years ago, so this new contact information is on the homepage. Current and draft regulations are there. Any news or updates and board meeting agendas and access information is there, as well as there's a tab called Pharmacy Practice Documents or Pharmacy Practice Updates or something like that. Anyway, if you go there, you'll find the advisories and policies and the circular letters in addition to the ones that we talked about today. There's also a compounding section like I talked about earlier, so everything should be there. Back in 2017, the board reinstituted the NABP newsletter. So this is a national newsletter that also they work with the state to do some state local information as well. We get hundreds of questions in at the board every year. So although there is some national news here, we take those questions that we get and we develop articles for the NABP newsletter. This is a quarterly newsletter. And if you'd like to receive this newsletter, you can go to the NABP website and sign up directly for it. You can sign up for any state, actually, if you go there and do that. Or you can email the board at this email address and ask to be placed on the distribution list. So if you're on the distribution list, you'll not only receive the newsletter, but you'll also receive any other information that we send out, whether they're updated policies or regulations or anything to that effect. We generally don't send more than 1 or 2 emails a month. And we don't share your email information. And if you're thinking, oh, well, the board has my email address, it's in my licensing, under my licensing profile, that's a completely separate database. So if you want these information to be distributed to you, then you actually do need to go in and sign up on the distribution list. You won't automatically receive it. Board meetings are the first Thursday of every month, and the public is invited to the first portion of the board meeting. Again, the agendas and access information are on the homepage. Right now, the meetings are still virtual. Here are the references of the pages we talked about and the documents we talked about today. So you can go ahead and access these from the homepage. Like I said, pretty much anything you want to get, you should be able to find from there. So that said, are there any questions that I may have missed or anything anybody would like to talk about? Let me see if I can see the questions.
Quite a few questions in the chat, but it looks like Bill was getting most of them.
Okay, are there any outstanding ones, Bill, that we need to talk about? Do you still need non-sterile compound credits for doing omeprazole and magic mouthwash? No, you only need the sterile compounding credits if you're doing complex compounding. So complex would be, you know, capsules, suppositories, or anything to that effect. These products, omeprazole and magic mouthwash, are considered simple to moderate under the old 795 terms, but they are not, you do not have to do CE credits for those.
Michelle, can you hear me?
Yes, I can.
There was a question on e-prescribing. Maybe David Johnson can handle that, you know, why it's not happening. Let's see here, some other questions. There was a question, Michelle, about the access law, about the 3-month requirement and how that will be verified. Basically, can we take the word of the patient? So we might have to check with the sexual health and reproductive program on that. But I suppose it would just be a profile review perhaps, but the patient could have got it somewhere else as well.
True, but you also could check with the insurance company too to make sure that they've completed their 3-month review as well, or their 3-month trial period as well.
Let's see what else we got here. I answered most of them already.
There's 2 new questions. Well, one is someone's asking to put the websites up again, but I think if you just, we could throw those in the chat.
I'm sorry?
Someone was asking to put the slide with the websites up again.
Oh.
But you could also paste them in the chat.
Our homepage, you can get any of these documents from our homepage. So if you just Google's a beautiful thing. Just Google mass.gov Board of Pharmacy, and you'll come to our homepage. And any of those other documents that we talked about already can be accessed from there.
Also, someone's asking about the 1-week waiting period for comments. That seems short.
For the public comment period, the public comment notices will go out, I believe, a month or 2 before the public comment period opens. So you'll have some time to review it before the period actually opens in order to make comments. And actually, all the draft regulations are currently located on our website, so you can review them now and decide, you know, when the time comes if you'd like to make comments.
Michelle, there's also a question about the unfilled Schedule 2 prescriptions. We do have a guidance document on that.
We do have a guidance document on that, but actually what we're doing is waiting for the DEA to weigh in on that, because the DEA has pending regulations on transferring unfilled prescriptions. So I think we're just the jury's out on that right now.
And then someone was asking, can you repeat what you said about the sterile NS compounding requirements?
You mean for CE? Is that the question?
That's what it says. Michelle, can you repeat what you said about the sterile NS? And she said yes.
Okay. So CEs are required for sterile compounding. You have to have 5 CEs credits every year if you are actually compounding or checking a compounded sterile product. Non-sterile is required if you are, again, compounding or checking a complex non-sterile compounded product. So a complex non-sterile compounded product would be something like suppositories or lollipops or something like that, or hazardous drugs. Typical compounding that you do in retail, like magic mouthwash or omeprazole kits, those are not considered complex, and you do not need the credits for that.
Michelle, we have a couple more questions that came in about tech trainees filling ADDs like Pyxis and Omnicell. We do have a new guidance document, which basically allows the pharmacy technician trainees to go out on the floor. And there's very specific requirements that it has to be in a licensed healthcare setting. There must be an on-site pharmacy. And again, we have a guidance document on our website that now allows technician trainees to stock ADDs in a healthcare facility. So we encourage you to look at our website.
Right, exactly. It's not C2s either. I believe it's only C6s, but I'd have to check the document.
No, I think it's C3 through C6 because the technician trainees can't handle Schedule 2s.
Right.
Let's see here. I'm just looking now. There was some question, Michelle, about the buprenorphine and the DEAX waiver. So the federal law has basically made changes to that, and Massachusetts will adhere to that. There's nothing more strict in Massachusetts on that. So
you can simply follow federal rules on that. If it's not needed, it's not needed. Anything else, Bill?
yeah, there's one just came in about sterile compounding pharmacists needing 25 credits. No, that's the only requirement for CDTM pharmacists, where they have to have a additional 5 credit hours in their practice area. So that wouldn't be the same for a sterile compounding pharmacist. It's just still 20 credits, but 5 of those must be in the area of sterile compounding.
Right. All the compounding credits can be counted within your 20. The only persons who need the extra credits are CDTM pharmacists, who do need 25 every calendar year.
And looks like there was one more question, Michelle, about do you still have to send letter to the board of where you work anytime it changes? How about flow to RPH?
No, you only need to notify the board when you're leaving a manager of record position of a Massachusetts pharmacy. You don't have to notify the board every time you change a job, only when you leave a manager position. Okay, I don't want to encroach too much on Dave Johnson's time, so I am going to just stop here. You can continue to put questions in the chat box and we can continue to answer them as we go through the next set of the presentation. So let me bounce out of here.
Great. I'm hoping David will pop. There's David. Excellent. Hi, David.
Hi.
Welcome.
Dave. Thank you.
So feel free to share your screen, but I will remind everyone David Johnson is the director of the Drug Control Program at the Mass Department of Public Health. And then I will recede into the background.
Okay. Can you see my screen now?
Yep.
And you can hear me okay?
Yes.
Okay. Hi, David Johnson, Drug Control Program. The Drug Control Program consists of things like the Prescription Monitoring Program, MAP, the Medication Administration Program in the group homes. We issue the mass controlled substance registrations for facilities and practitioners, pharmaceutical code of conduct, essentially anything that the legislature passes that and we implement regarding the safe storage, administration, prescribing, etc. Those are regs. Michelle covered quite a bit of what I'm going to talk about. I'll go in a little bit more depth. We'll go over e-prescribing updates and issues, where we are, where we're headed, the rise of fraudulent e-prescriptions, unfortunately, extremely frustrating and troubling. Then we'll go over some of the amendments to the 105-700 regs that were published on Friday. We did pretty much a complete overhaul, and there are a couple of items in there that are related to pharmacy practice. Michelle touched on them. And then I'll go over updates to the PMP reporting requirements, coming enhancements, and we'll move on from there. So here are the learning objectives. So you're going to be able to summarize those 700 changes to the regulations. You're going to identify changes to the patient report in the PMP and describe the requirements of reporting naloxone. And then you'll summarize the status of e-prescribing in mass and the pharmacist's role. So here's where we are with e-prescribing. That blue line, we're up about right around 90% of the prescriptions that are coming into the PMP for 2 through 5s are issued electronically. There's 5% that is unknown, and that is just sort of left blank. We'd like a little more information. We'll be reaching out to some of those pharmacies that are not reporting the type of prescription. Now that's not bad, but it's not, 10% is not great that are still being issued as written prescriptions. And we'll get into a couple of those, the reasons, the roadblocks. For the most part, long-term care facilities had a waiver up until January 1st of this year, 2023. They've made great strides. There's about 90% of those are e-prescribing at this point. And so we have become a little bit more aggressive. We started off coaxing people into compliance. And lately we've been going after the high prescribers a little more aggressively and getting them on board. The state also finally entered into a contract for its facilities for an EHR system that will have e-prescribing capacity, and that will help as well. But several roadblocks remain. One positive, or one development that might help, is that CMS, who had a law on the books to mandate e-prescribing, has finally implemented that mandate. It's not terribly restrictive. Beginning this past January 1st, 2 through 5s for Part D, and any prescriber who issues one of those prescriptions and issues more than 100 of them in a calendar year is required to electronically transmit at least 70% of these 2 through 5s, not sure where that came from, to patients with Medicare Part D within a calendar year. So at least the mandate is up, but they are exempting anybody who issues less than 100. And even with the mandate, you only have to e-prescribe 70%. I would think if you have an e-prescribing system, you would e-prescribe from that system. So how are they going to determine compliance? Well, at the end of this calendar year, they're going to do a review. And based on claim submission and processing, they're going to see who is in compliance. And if you're not, they're going to send you the dreaded non-compliance notice, which would scare anyone, I would think. So we'll see if that kind of helps bump up our numbers at all. But wanted you to be aware of that. So there are some problems that are making some of these roadblocks that I mentioned. One of them is the frustration with the current e-prescribing system by practitioners with the inability for a pharmacy to forward medication in 2 through 5 to another pharmacy if they are out of stock. So for example, with the Adderall shortage, there's a large psychiatric practice that wants a waiver. They want to go back to written prescriptions for stimulants because they issue the electronic prescription to a pharmacy. The pharmacy doesn't have it. The patient has to come back. That prescription is canceled, they have to issue it to another pharmacy. They want to just give the written prescription to the patient so that they can shop it around. You should know that this is available, this feature is currently available for Schedule 6 medications. SureScripts representative said he was very surprised on how few pharmacies have signed up for this feature. So you can contact support@surescripts.com, and this will give you the ability to forward a Schedule 6 prescription to another pharmacy directly if you do not have that medication in stock, or you can't fill it for whatever reason. It does not have to, in this case, go back to the prescriber. So why not the Schedule 2 through 5 forwarding? Well, in order to make it happen, there has to be a new NCPDP script version that is rolled out and adopted by the industry. It's been ready to get rolled out for quite some time now, but in the Medicare Prescription Drug Improvement and Modernization Act, there's a paragraph that gives CMS the authority to set the standards for the e-prescribing format. And so CMS must approve each version of the NCPDP script before it can be rolled out. SureScripts has been urging CMS to act. CMS seems to be in no hurry. I don't know that they know the issues that they're causing by not acting. There is legislation that would remove CMS's authority. SureScripts and others in the field believe that this is not helpful. If you have new technology that can be adopted into the system, and in this case, the new NCPDP script is being updated to allow this feature to happen, why are we waiting for CMS? So those of you who are politically connected or want to see this feature, some political pressure could always help to get this rolled out. It is a considerable roadblock and really does frustrate both patients and prescribers. So written prescriptions are not going to go away for quite a while, because there are exceptions in the regulation and statute, and those include those issued by veterinarians. They seem to be exempt from everything. The prescriptions issued where there's some temporary electronic failure, etc. There's waivers. We are still granting waivers to, these are primarily older practitioners who have 10, 12 patients left. They issue fewer than 100 controlled substances for prescriptions for the year. We do a review of their prescribing patterns in the prescription monitoring program. We have denied quite a few this round to bring people on board. We also know that there are practitioners out there that are issuing written prescriptions. They don't have a waiver. And we're trying to track those folks down and get them on board and get a system so we can bring up that level. Another big problem are the hospitals, in fact, who seem to be issuing written prescriptions. You get it with your discharge papers after you've had a procedure, and there is a controlled substance prescription on paper, and they're done with you. They're not taking the time to e-prescribe to a pharmacy of the patient's choice. So we at DCP, we've got some work to do to try and bring this into compliance. We changed the exemption for the long-term care facilities. They're very close, but CMS in their mandate extended the long-term care exemption to January 1st of 2025. So we thought that we might as well just get in line with CMS, so there's not sort of conflicting requirements here, and a good number of these prescriptions are going to be Medicare Part D anyway. A real frustrating thing when you're trying to get e-prescriptions, e-prescribing and implemented, and the logic has been that this will reduce fraudulent prescriptions. Well, now, of course, we're starting to see prescriptions come into the state that are or being issued, and they're fraudulent. As far as we know, the system in not one of the approved systems has been hacked electronically, providing a tech wizard to get access and start issuing e-prescriptions. They are all as a result of identity theft. And thus far, they have all been for promethazine with codeine. Now, in some sense, I almost would prefer that it was hacked, because that would be an easier technological fix to patch the vulnerabilities and be done with it. In this case, identity theft, it's fairly easy to find a prescriber's credentials somewhere online. During a staff meeting, one of the PMP staff made it all the way to the payment page for an e-prescribing system on your smartphone, and that's troubling. How these systems, the due diligence to ensure that you're not opening an account to someone who shouldn't have one is crucial to make this system secure. So we also have a case that, and this was a tip from a pharmacist, a physician assistant was writing prescriptions, and the pharmacist noticed that the PA was coming in to pick them all up for about 13 different patients. And that PA was clever enough to know that when the urgent care center was closed, there was an emergency, a way to get into the urgent care system to issue a prescription after hours, and also figured out that a lot of the security features through this web portal were not in place when issuing those prescriptions. So was able to issue the prescription and then delete it so that his supervisor did not see it wasn't in the urgent care system. He was able to use a separate telephone number, etc., and manipulate the system. So anyway, it just makes me admire how how smart they are sometimes. But it would be really great if you do come across a fraudulent prescription to contact SureScripts. They will act on it quickly. They have an anti-fraud or a unit, and they would disable these accounts quickly. And if you wouldn't mind, reporting it to the drug control program, we like to monitor this stuff. We are in constant communication, trying to put pressure to make this system more secure. It's tough, forcing people to get on board when what you have is a badly flawed system in some people's eyes. So essentially, if it's promethazine by codeine, okay, chances are it's a fraudulent script. That is the new, drug of choice for the SIP, the various names it's called, and it's expensive out there on the street. So there's a lot of incentive to try and get this drug. And then if it's a out-of-state prescriber for promethazine, even worse with codeine. And then finally, if prescriptions are being issued off hours. If you know the urgent care near you, it closes at 8 and you're getting a prescription issued at midnight, maybe it's an emergency, but maybe there's a chance that, you know, something is going on here. So be diligent and hopefully we get some changes. So again, Michelle went over this, you know, the pharmacist role is not to be the police person here. You know, I will mention that, you know, it's somewhat related, but I was speaking to our sister bureau within the Department of Public Health of Substance and Addiction Services, and they're finding that pharmacists regarding the ID requirement are not filling buprenorphine, Suboxone prescriptions. And if you are in an area where there is a homeless population, there is the kind of workaround that that ID requirement. BSAS, the department would be very grateful if you would err on the side that this is a person who does not have an ID and not withhold their buprenorphine, their Suboxone. It's a life-saving drug. So anyway, that just wanted to cover that before we move on. Again, back to e-prescribing. You can assume that it is a valid prescription, that there's an exception applies. You can fill those prescriptions. So moving on to the amendments in the 700 regs, we just did a complete rewrite. We're very proud of it. It's almost readable at this point. So there are a couple of changes. Michelle, I believe, covered this one, but so a pharmacist, and this was existing in the reg, may administer medications for treatment of mental health or substance use disorders at the direction of a prescribing practitioner. And that is provided that the pharmacy is authorized to dispense. So if you're registered, and yep, and it's pursuant to a valid prescription. And in the reg was that such dose is not the first dose of such agent the person has received. The Chain Drug Store Council requested that we remove this requirement. We did. There was no objection. And so now pharmacists are able to administer the first dose of one of these drugs. So you can also see that well, there will be new guidance, a new circular that will be posted tomorrow that will add a drug to this list. That's where you can see the list of drugs, and this one is a new formulation of the Invega. There's two. For schizophrenia, Invega has two formulations, you know, a monthly, a 3 times a year, and the new one is Invega half-year, which half-year, I believe, is Latin for twice a year. And so that circular will be coming out and posted tomorrow. Also new and in now, and this was made available in the PrEP Act as well, the pharmacist is now able and authorized to administer controlled substances in an opioid treatment program. Pharmacists have been key players in the OTPs, and this now makes it official in regulation that they are authorized to administer those substances in an OTP. Michelle mentioned that there are changes, and also in the PrEP Act. The PrEP Act allowed the pharmacist and intern and technician to administer to 3 years of age the Bureau of Infectious Diseases, BIDLS, wasn't keen on 3 years of age. So they requested that it be lowered to 5 years of age. So that now is officially in regulation, that pharmacists are able to administer those vaccines on the list, and COVID vaccine to those who are 5 years of age and older. Okay, and Michelle covered this as well. This, of course, I think is old news to you, but we've officially got it out of the regulation that nurse practitioners, there are nurse practitioners, if you've had more than 2 years experience, you are able to operate without a supervisor. And it really became impossible to try and come up with regulations that has their name, supervisor's name on those that have supervisors and those that don't. But they can now enter into, they can practice without a supervisor, open up, throw out their own shingle. Their name, the name of the supervisor does not have to appear on their prescription. Okay, changing to some of the PMP updates. I'm not going to go through these with you because chances are you are not the data submitter for your pharmacy, but these can on the PMP website. And if you do get a set of these slides, you can alert the changes to the reporting requirements for the PMP, just to kind of update and we hope clarify some of these, some of the issues that we've been seeing. Not a lot of new requirements except the date sold. So the date sold was, we were requested by numerous stakeholders to add a date sold column to the patient report. The patient report currently has a date written and a date filled. And we always went with the idea that the date filled was the date that the prescription was sold, was left the store. But that's not been the case. And there have been many instances where the patient said, I didn't pick that up for 5 days, or and so for some of the shorter duration prescriptions and things like Suboxone that typically are 7 days old, and they said, well, here it is on the prescription monitoring program. So they asked that we put in that date sold. So for pharmacies that have that point of sale system, we're asking that they include the day essentially it was sold and left the store, so that this can be populated and it will give a clearer picture to the prescriber, to the practitioner who's reviewing the patient's report. We've started collecting it. There are only a couple of pharmacies that are not submitting this information. We want to get it up to 100%. And then we will turn on that date sold feature and column in the patient's PMP report. And that hopefully will be coming in, I'd say a couple of months. Maybe we will turn it on, having enough data to go back, so that, right now, if we turned it on, I think there would be some blanks and it would look like the patient never picked it up. And we want to get over that hump first. So naloxone, I just wanted to clarify and make sure, because there was some issues with our requiring or requesting that the naloxone be reported to the PMP. And this is a separate section of Chapter 94C that requires a pharmacy to annually report their naloxone dispensations to the department. That data that they were receiving on spreadsheets, and it was incomplete. It was not very informative. The reason why the department wants this information is because they spend a lot of resources trying to ensure that naloxone is available. And they want to see where it is being dispensed in different regions of the state, what kind of outreach, what kind of, get a sense, is it based on a standing order? Was it an individual prescriber? All of the kind of initiatives that they have, they can, do an assessment, and the prescription monitoring data is much more complete, and you can automate it and get it to us on a daily basis. Now, it is not going to appear on the patient's report, because we know that some people who are not, it's not intended for their own use, can go in and purchase it or have it charged their insurance company, et cetera. That there's and so we wanted to avoid having it appear on a patient's report. That information is suppressed. So it's just essentially sending the data and using the PMP as a data repository for this information. We then give it to BSAS for their program analysis. So it is also important that that an ID is not required for naloxone. So once there, I guess, was a misconception, and probably was my fault for not clarifying quickly and clearly enough, because it's being collected by the PMP, it does not mean that a patient ID is required. And we have a workaround in the data submission guide. So coming attractions, that date sold column, there's also, for those of you working in an integrated setting, there will be a patient pick list. If right now, if there's two profiles that kind of fit the patient, you're getting a notice saying multiple options, go log into MassPat, and which is a pain in the neck. In your integrated setting, when most of you are working where it's now integrated into your pharmacy software system, you'll have that pick list and see the patient that you want, and we'll be able to accommodate an announcement tile. We're at the end, so I'm gonna kind of skip through, but these just are the opioid prescribing. The green is the utilization of the PMP. It keeps growing very high, almost climbing to 4 million searches a quarter in the program, which has been a great help to us. I wanted to go over stimulants because we're seeing all of these online telehealth prescribing, that is, these companies are popping up during COVID, and the DEA waived that in-person requirement during COVID. They're kind of scrambling now because these COVID, these telehealth sites are popping up and making it pretty easy to get stimulants online. According to the DEA, their new ones are cropping up every week. And they're applying for DEAs in Massachusetts, which is a requirement, even though they might be in Kansas. And they're renting a WeWorks kind of place, a little office where it's not an office at all. It's just the company orders. And so anyway, you're seeing a massive rise, I'm sure, and this could be contributing to the shortages. So more on that to come. But anyway, are there any questions for me? Oh, I guess I can figure that out. Huh?
David, there have been lots of questions in the chat, but I think a lot of them have been picked up.
Okay.
But if you scroll through, I'm sure you'll see. And some of them are questions for Michelle or more general questions.
Yep. Okay. Yep. No ID was required for Suboxone. ID for Suboxone. No ID is required. Well, the workaround, sorry, good question. The workaround is the if the person says, I don't have an ID, which the homeless typically do not, then if you have a signature pad, just have them sign the signature pad. If you have them sign anything, the workaround in the dispensing guide is old, and it was, have them sign the back of the prescription. So I think for Suboxone, we're going to be as liberal as possible. Please don't let the lack of an ID, prevent you from filling those prescriptions. So according to the regional director for the DEA office, that waiver for in-person visit was set to expire in mid-January, but I keep checking in, and there's nothing yet that has waived that COVID flexibility. Is the DEA working on getting rid of teleprompters since abuse? I'm not sure which direction they're going to go, because there are some great advantages to telehealth. It doesn't seem to be going away. They have requirements that if you get rid of these flexibilities from COVID, it's going to impede, at least for the controlled substances, and it's primarily the stimulants. So I'm not sure what direction they will head with this. They keep wanting to work with us and wanting us to reject these applications for mass controlled substance registrations by practitioner if we know that it's at 75 State Street, where there's now about 100 practitioners who are all part of this one WeWorks kind of office, where it's clear that they're not there. And that having that Massachusetts address allows them to get a Massachusetts DEA, because that is a requirement that was also waived during COVID. If you had a DEA in another state, you could write in Massachusetts, and they want to pull back on that. And okay, if you're going to be a Massachusetts prescriber, you have to have a Massachusetts practice location. We don't regulate telehealth. So we're trying to work with the DEA, but there's only so much that we can do. If the employer rents out a space, for example, and you're allowed to then work from home, if that home is in another state, can we deny them a mass controlled substance registration? So
maybe just one or two more, David. I know it's approaching the lunch break.
Yep, sorry. Yes, I'm the customer signed RX is antiquated. And we'll try and get some guidance out there as quickly as possible. Yes, the signature pad can replace that customer signed RX. And yes, customer signed RX still should be translated to the PMP in this case. Very good question. And I will work to get that guidance out as quickly as possible. Okay, sorry, I took up a little too much time.
No, great, good questions, great presentation for both you and Michelle, and thank you, Bill, for answering questions in the chat. So we'll get started with our next presenter. Very pleased to welcome Shabir Safdar, who is the Executive Director of the Partnership for Safe Medicines, to talk to us about recent incidents of counterfeit medicine in the supply chain. And Shabir, I hope I got your name right.
all good.
Thank you.
All right, shall I take it away?
Yes, please.
All right, so let me just confirm that everybody can see the presentation that I'm sharing now.
Yep.
Okay, so David, if you would help keep an eye on the chat with me, I love
do.
to take questions as the event is going and as the slides are going. So if you have a question that is relevant to what's on screen, please take a moment and put it in the chat, and David and I will try and catch it and answer it as we go. I'm going to describe what we're going to do here. I'm going to cover counterfeits that we found in the supply chain, and then I'm going to move into the Drug Supply Chain Act, specifically in how it affects pharmacists and pharmacies. I'm going to go a little bit fast through the counterfeit incidences and try and spend as much time as possible on the DSCSA, because it is kind of an amazing system and it's coming online this year. So if you didn't happen to look at the learning objectives, this is what they are. And if you're not familiar with the Partnership for Safe Medicine or not, we are a coalition of people who handle medicine from the factory floor to the patient. So there's a lot of pharmacist organizations that are members, many state pharmacy organizations and the nationals. And then we've got some patient groups that have been concerned about safety. We've also got manufacturers and wholesalers who are members of our organization. We don't accept any membership from for-profits or insurance companies or PBMs, and you can buy me a martini and I can explain why that is some other time. We've been studying this topic for about 20 years. We've studied everything from fake pill deaths linked to social media, the new emerging problem of counterfeit Adderall. You can find about a video a week on our YouTube channel, and we have a special section of our website for pharmacist education at safemedicines.org/pharmacists. I'm going to take a quick moment and put up a clock here so I don't run over my own time. And all right. So in this course, we're going to specifically talk about, as I mentioned, some major counterfeit incidences, how the DSCSA works, and what pharmacists are meant to do. But to talk about that, I first have to actually talk about some of the problems we've had in the US with counterfeit medicine. One of the oldest cases we've had was counterfeit Procrit and Epigen in the early 2000s, making their way into the legitimate supply chain, into some of the big three wholesalers, going to pharmacies, and pharmacists unknowingly dispensing it to patients. One of the victims of this era was Maxine Blunt. Her brother, Max, actually testified in front of Congress in the wake of this scandal. And you can see here, because of the technique they used called up-labeling, that the vials that were used looked very similar, the counterfeits, to the real ones, because they actually used real low-dose vials relabeled as high-dose medicine and only made some minor errors on the labels. I don't know how anyone could have spotted this, even if you handle these vials every day, how you might have noticed the small misprints in here. This is actually the technique that was used. As you see, Epigen, as an example, comes through as 3 doses. It's 2,000 units per ml, 10,000 and 20,000. The packaging is very similar. And so in this case, the criminals took advantage of that. What they did was they took the low dose product, which they managed to find a corruptible pharmacy to sell them, I think, upwards of 100,000 vials. And then they soaked the labels off, believe it or not, in paint cans with paint thinner in a Florida trailer park. And then they managed to print counterfeit labels and put them back on. And with that event, they turned a $25 a vial medicine into a $470 vial of medicine. Do that 100,000 times, and you can imagine the profit motive and the motivation of the criminals here. Now, they had a problem, though, which is that, and this gets to what we're looking for in the DSCSA, they couldn't actually just turn around and walk up to one of the big three wholesalers and say, I've got some really cheap Epigen for you. I know that it's supposed to cost $470 a vial, but I've got it for $25. They would have been laughed out of the room. And so instead what they did was they used the ease with which you could get a pharmaceutical wholesaler's license in the early 2000s, especially in Florida, and the low amount of staff dedicated to inspections and compliance. And they sold and resold these products through a variety of wholesalers, many of whom never even took possession of the medicine. The product would sit in the warehouse of one of the early criminals and then be sold and resold on paper without ever physically moving until it got to a price that was more believable. And then they would sell it to one of the major wholesalers who would take that product and set it down in the warehouse right next to the product that had actually come straight from the manufacturer, making it completely laundered. You can learn more about this case. This is a true story. In the wake of this crime, a Florida grand jury was convened, and they came up with some policy recommendations, and then it was written as a bestseller by Catherine Eban in a book called Dangerous Doses, which is probably optioned for a film, but as far as I know, has never been made into a film. If you go to this URL or scan the barcode, the QR code on my slide, you can actually go and take a look at our page about it. The next big wave of counterfeits that we are particularly concerned about and documented was a wave of counterfeit Avastin that was sold by a number of rings from about 2008 to 2012. And it was sold primarily by wholesalers who were interested in selling directly to physicians who did administration in office and did not work with the hospital. Now, you'll hear me say this a lot. I've said this for a decade, but pharmacists are one of the safest parts of the supply chain, and they're rarely involved in counterfeiting schemes because they tend to catch and have a lot of familiarity with the regulatory and licensing requirements of what it takes to be a pharmaceutical wholesaler. Physicians who operate independent oncology practices are not, in fact, familiar with the regulatory system that covers pharmaceutical wholesalers. And so these criminal wholesalers who were trafficking in black market Avastin and other injectables were marketing directly to physicians. And this is a crime that continues today. You know, there are people who attempt to sell to independent, non-hospital practicing physicians because they don't have the same compliance regime that a hospital or institution has, and they don't use a pharmacist for their pharmaceutical procurement for medicines that they administer, let's say in an infusion chair in office. And so the same person in their small independent medical practice that orders lunch and copier paper is also ordering pharmaceuticals, and they're more easily fooled by a blast faxer selling something and may not even know that a license is needed. So what happened is a number of these rings sold this product, this fake Avastin, and one of the victims was a woman who was in cancer treatment in Chandler, Arizona, named Betty Hunter. And unfortunately, the product was not sterile. It should have just been, in an ideal world where counterfeiters do their job well, saline in a bottle. But it was made in such a way that was not sterile. And over the time it took to get all the way from Europe to here, being sold and resold through wholesalers to hide its provenance, it developed mold. And so Betty Hunter was in an infusion chair and got fake Avastin with mold injected into her, had a reaction. The oncology nurse saved her life by unplugging her and calling an ambulance where she was taken care of. And she eventually did succumb to her cancer. And she said to her sons before the end, you know, that she felt like medicine wasn't working and she actually needed to switch doctors because the doctor had assured her that the medicine was fine, never told her that it was being bought from a black marketer. As I mentioned before, the product they think may have been made in Syria, but its first known handoff was from Turkey, which is actually, if you talk to brand security people, a popular source of counterfeit medicines. It was then sold and resold through entities in Switzerland and Denmark and the UK before finally ending up in the US. And to cover their tracks even more, sold by drop shippers in places like Montana and Tennessee. So your physician in the US who was buying didn't know that they were buying from the UK or from Canada, which is where one of the rings, Canada Drugs Wholesale, was located. They were mostly thinking that they were doing business with Americans. And again, hiding the provenance of something by papering it over with receipts of people who sold and resold it hid the true source. And it wasn't just Avastin. This is a list of all the drugs that these black market rings were passing along. And they were obviously focusing on people who were the most likely to fall for it, which is physicians practicing independently without a compliance or pharmacy department, and who were looking to make an extra buck. Here's some examples of the product. I mean, it gives you a sense of just how gullible independent physicians can be, at least their staff, because it wasn't even in some cases printed in English. And I've actually spoken to oncology nurses in practices where the doctors bought these, they saw the foreign writing and immediately quarantined the product. But physicians thought, well, it's the same thing, but for a cheaper price from a foreign source. I'm sure it's fine. I've actually heard physicians tell me that. And the drop shippers were in Washington, Illinois, and Tennessee. There was a sales office in Montana, but they were actually bringing the stuff into the country and then in some cases repackaging it. What's even worse, in some cases, they would use insufficient products to chill the cold chain oncology products, right? And so they would sometimes, like use a lunch pack, which is really awful. And if they would arrive warm, they would of course ship them back and say, we're not going to accept delivery of this product. And in the case of Canada Drugs, which is one of the several rings that was doing it, their sellers would just repack the product with more ice packs and then send it back to another customer. There was no regard for patient safety or handling of this. The FDA did a warning back in 2012, and then they started sending letters as they unraveled the scheme to different people involved in it. The whole timeline of one of the rings, Canada Drugs Wholesale, was pretty significant. It took a long time. They had issued warning letters. They had raided one of their warehouses. Eventually, they were planning to do extradition, and that didn't work out, which I will show you in a minute. But there were 3-4 other folks that worked on this crime that had their own rings, and they were all brought through the justice system, primarily because their staff was in the U.S. Now there's a comment in the chat that many of our medicines are made in China, and that's true. But that doesn't mean that all medicines from China are safe, by the way. Only ones that are made in FDA inspected factories can even assume to be safe. If you look at the recent incident of baby medication that's been made with diethylene glycol or antifreeze that's been circulated in Kenya, I believe, it's a proof that, the difference between an FDA inspected production line and one that is not is significant and may involve your life. So once the FDA was done unraveling all of the players, they started sending warning letters to medical practices that had bought from these black marketers, these 4 or 5 rings. And we actually took time to make a map of it. And it basically was in 48 states and Puerto Rico. It was just amazing the breadth that these people had and the number of people that purchased from them. In New Jersey, of the number of medical practices the FDA warned because they found evidence of them doing business with unlicensed and foreign entities that had been through the justice system for selling black market medicines. There's a map like this for just about every state. I think maybe South Dakota, maybe one of the states where there's not a lot of these. There's a question in the chat, by the way, that are all sites in China actually FDA inspected? So there are a number of sites in China that manufacture API or products for the US market that are FDA inspected, but you have to understand that there are hundreds, if not thousands of more production facilities in China that are not inspected. They make medicine for, let's say, Nigeria or Kenya or the UK or Belgium. These are not inspected by the FDA. And they're probably in some cases not inspected even by those countries because they don't have the staff like the FDA does. And yet they make counterfeits that look just like the real thing. So how did this all end? So for one of the rings, the leader was a pharmacist in Canada, and he was basically refused to let himself be refused to come to court. He refused to participate in the legal proceedings against him, and he'd made so much money. When he was indicted, just for the counterfeit Avastin ring, they said that there was $78 million of sales to U.S. doctors, which is an enormous amount of money. But because that money also pays for good lawyers, he was able to refuse to come and fight the extradition, and he finally won. The U.S. gave up extraditing him and settled with a plea bargain, and he actually got his pharmacy license back, believe it or not. So imagine if you're a pharmacist in the U.S., you run a company that has done $78 million worth of documented black market sales, including outright counterfeits to pharmacies, to medical in the U.S. I can't imagine that you could be a practicing pharmacist still, but he is today, and he would really he didn't serve any jail time. He just proceeded to continue on with his life after doing about 4.5 years of I'll call it house arrest and probation. Pretty easy sentence, if you ask. If you want to take a look at the sort of full breadth of this issue, you can take, by scanning this QR code at our publication about counterfeit cancer drugs in the U.S. I mentioned again that this crime still persists. The big rings doing it are not out there anymore, as far as we know, but oncologists still are out there buying these products from foreign sources, claiming that they're the same thing and then giving them to patients. So there's some recent threats I want to touch on. Mexican border pharmacies and Mexican tourist destination pharmacies like in Cancun have been targeting Americans. This is the Purple Pharmacy chain, which actually has a number of sites. If you go to Los Algodones, Mexico, which is 15 minutes from Yuma, it's a short drive, and there's probably about half a dozen of these border pharmacies there catering to Americans. And we were notified in early 2022 of a counterfeit blood thinner, and I think it corresponded at the same time correlated with the removal of one of the blood thinners from a PBM's formulary. It might have been CVS Caremark at the beginning of 2022, and it was out for 6 months. It certainly sent a lot of patients scrambling. These are both a map of where undercover agents working with the Pharmaceutical Security Institute and the manufacturers found these products. All three of these bottles that you're looking at are products that were just placebo, that were sold in these border pharmacies. The left two are chilling in my mind. They are counterfeits that were printed with labels in English, and obviously placebo in the bottle. The right one is actually not what Eliquis is sold as in Mexico. Eliquis, I believe, is sold in a blister pack in Mexico. So that's not even the right packaging, but it is the right packaging if you're trying to fool an American, and it's in Spanish. So if you're an American who's not paying attention, you'd go down there and be like, look at this cheap Eliquis. It's got a label I can read. But if you're clever, you might think to yourself, well, Eliquis in Mexico should be in Spanish, so I want the one that's got the Spanish label. Well, they got you that way too. They basically got you coming and going. And you can tell only in one case of these three a blatant error on the label. If you look at the middle picture of the Eliquis and you turn your head sideways and the UPC code, it's 012345678912, which I can assure you is not the real UPC code for Eliquis. We've got a PSA you can share with patients about the dangers of buying medicines in Mexico on our website and our YouTube channel. If you scan that QR code, you can see it. But this is not an isolated incident. There are tons of really dangerous counterfeits labeled in English floating around Mexico. Another threat in the supply chain but not through pharmacies that we've seen over the last 5 years has been fake Adderall made with methamphetamine. In a couple of cases, we've seen it made with fentanyl, but really the traditional way of making counterfeit Adderall is to fill it with meth and sell it. And we've seen it in over 20 so far, and because it's been adopted as a revenue product by Mexican cartels, we're seeing it smuggled in bulk from the South. And so that is another new threat. So before I hit this biggest case we've ever seen that will lead into the DSCSA issues, I want to address a question that was in the chat, which is that many patients still use pharmacy online and Canadian pharmacies to get their medications. How do we guide these patients to make sure they're receiving safe medication if costs are the real barrier? And the answer is there's no way to guide a patient to a Canadian pharmacy that is safe. Canadian pharmacists are not allowed to dispense to Americans. It's just not legal. So from the get-go, if you've got a patient using that, they're basically doing something safe and not legal for the foreign pharmacist. And doing something like that is not safe. If they've got cost issues, there's not an answer for every situation, but patients assistance programs is places I would turn. Our outreach is a U.S. bricks and mortar or pharmacy that serves people who have financial challenge. Those are all places I would go. So one of the cases I've ever seen was ongoing is a diversion and counterfeiting case, and it starts with pharmacists who are getting offers like this. And if you get these, let us know at editors@safemedicines.org. Someone is offering you, let's say, a hepatitis C or an HIV medication below cost, and it's below what you would even get it even through a buying group from a major wholesaler. And they'll of course offer to give you their DSCS transaction sales log to show the math. And the sales history, could look like this. It's come from Gilead Sciences to AmerisourceBergen, and from AmerisourceBergen to another wholesaler, and another wholesaler to you. They may actually tell you at some point that, one of the wholesalers was in Puerto Rico and it came back, or it's near expiration and they got to get rid of it. But it's all a fiction. And in fact, the greatest story that's come out of this case so far is a community pharmacist in Texas. And he and his buying group were told by AmerisourceBergen that they're getting the very cheapest price on an HIV medication that Gilead makes. And then one of these gray marketers came to him and said, I've got it for this price that's super. I'll give you a transaction log so that you can see that it's real. He took receipt of the medicine, he looked at it, and he looked at the transaction log. It was coming through AmerisourceBergen, and he said, that can't be. AmerisourceBergen has told my buying group that we get the best price, but clearly somebody else's, because AmerisourceBergen sold it to 2 other people, and by the time it got to me, it's still cheaper than what we get. So he asked AmerisourceBergen what the deal was, and they came back and said, we've looked at your transaction log, we've looked at the serial number, and these medicines were never in our warehouse. And so that was the realization for him that the transaction log was fake, and that these medicines were either diverted or counterfeit. But obviously, if either of those are true, it's not safe to give to patients. And he returned it to the wholesaler, the criminal wholesaler. The medicine should have been quarantined. That's a learning experience for him. But it shows that actually the Drug Supply Chain Security Act and those serial numbers are actually really, really important already, even though the whole system is not fully in place. You can follow more about this if you take a look at this QR code. We're following this case, which is still ongoing. What happened is that there were entities that had constructed a criminal conspiracy to divert and counterfeit medicines, and we started to get hints of it starting in 2020 when both Janssen and Gilead warned that their HIV medicine was being diverted and counterfeited and put back into the supply chain through bricks and mortar pharmacies. And Gilead actually finally made some of the information public from their court cases. And so this is how the scheme works. The criminals were buying either medicine or empty bottles from indigent patients who get their medicine very cheaply. So in some cases, they would pay some amount of money for an empty bottle that has labeling and the Drug Supply Chain Security Act barcode and serial numbers on it. And in some cases, patients were getting medicine that they were then just selling outright instead of taking. They would then forge a transaction log claiming that it went through individuals and entities that it did not go through. And then they would start to reach out to pharmacists. If they had bought an empty bottle, they would just throw whatever they had handy in it. In the best scenario, they put in pebbles or Tylenol. In the worst scenario, in one case, they put in Quell. And the individual actually wasn't paying attention to the fact that the pills were different, took them, and was unable to move or speak for several hours until it wore off. So it was not without consequence. And they would then, at the end of the process, start selling it to bricks and mortar pharmacies, to pharmacists who thought they were getting a bargain. At the time that this was first revealed, they had so far managed to get their hands on, through the court case, 85,000 bottles with a retail value of about $250 million, making it the largest counterfeiting and diversion case I've seen in my life. I mentioned before that some of the fake product had reached patients, and as of now, actually, there's over 170 defendants as part of the lawsuit. And it's complicated. You know, there were ringleaders, suppliers, distributors, pharmacies, marketers, and money launderers. And it was not just some HIV medicines. There's a large variety of medicines from a large variety of manufacturers here. And to be clear, these medicines did not pass through the hands of any of the big three, right? They went from, at least not directly, you know, they were dispensed to patients, and then the criminals bought them either empty bottles or full bottles from patients, and then faked that they went through a major entity, a major wholesaler, and then sold them to pharmacies. The lawsuits that are happening now are not criminal lawsuits yet, although there is some who've drawn some criminal charges. This case is really being prosecuted by attorneys, outside counsel for Gilead and Janssen, using a civil act called the Lanham Act, which is a trademark violation statute. And it is very, very serious. It's what's called a strict liability statute. So any entity involved in trafficking this medication can't say they didn't know as part of their defense. And it's traditionally been used for fake apparel, but it's now actually being used for these pharmaceuticals, and it lets the trademark holder, let's say Gilead, sue entities in the supply chain who were trafficking in the counterfeit medication for the actual loss of the value of the product, but also penalties on top of that, profits, and attorney's fees. And that's a really expensive event. I don't know that is an experience that anybody wants to go through. Some of the pharmacies that were egregious in buying this too cheap to be true medicine ended up in the lawsuit. A small handful of them that were warned before they did a purchase, and then after they did a purchase again, that they were doing business with entities known to traffic in counterfeits, ended up getting sued under the Lanham Act as well. And for a small community pharmacy, I feel like a Lanham Act prosecution civil case, given the penalties, could be a bankruptcy triggering event. So it's important that you know that pharmacies have an obligation today to look at and quarantine suspect product and investigate its provenance, which I'm going to talk about here in just a minute. Even though the Drug Supply Chain Security Act's final step doesn't go into effect until November, the obligation that you have is to investigate and quarantine suspect product is enforced today. So the incidences I told you before, which is about the counterfeit Procrit and Epigen and Avastin, really drove home the point that the U.S. drug supply chain in some part was running on trust, and that was not good. There was no way to do the Reagan-esque idea of trust but verify. The verification part was not nearly impossible to do, and that traceability was an important aspect that we needed to add. And it was not an easy debate to have. It's very expensive for many participants in a supply chain to implement a traceability and serialization system. So how it got done was a long multi-year debate. But finally in 2013, Congress, attempting to preempt a patchwork of state traceability proposals, went ahead and set something up called the DSCSA. It was enacted in 2013. And the way it was constructed actually was to the benefit of pharmacies. Everybody else in the supply chain altered their systems first before it arrived at pharmacies. So the first people to suffer and do the implementation were manufacturers. And manufacturers got their labels changed to account for the serial numbers and other things as they many years ago, and have been doing that. And then wholesalers started changing their systems to process, scan, and do electronic data transfer from the manufacturers, and they're getting ready now to set that up to do that tracing and data transfer with pharmacies, although everybody feels that the November deadline is coming faster than anybody is comfortable with. As a pharmacy, you're probably going to simply rely on the IT system that runs your pharmacy's inventory to actually implement that data transfer with the wholesalers. I'm guessing in many cases, many pharmacies will not have to buy extra products, although you might want to because you need some of the provisions that the functionality they provide. Before I explain what the DSCSA is, let me actually explain what it's not. It is not edible microtags. It's not RFID tags. It doesn't have anything to do with blockchain, although there are DSCSA add-on products that involve blockchain. There's no watermarks. There's no scratch-off tags to verify. What it really is a combination of technology and legal obligations and standards. It allows traceability, but it's not an instant system. You don't press a button and see where a particular serial numbered vial or bottle is in the system. It covers, though, the entire supply chain up to dispensers and including dispensers, but not patients. And actually that is a very well thought out detail, because so many medicines change packaging and format between the dispenser and the patient. If you had to carry through that serial number through that point, it would actually create a significant burden on the pharmacies. And it would require a behavior change from patients. And so I think that's actually been a really wise decision that saved a lot of money for pharmacies and logistical information. So this is a fake bottle that has the 4 numbers on it that you would see as part of serialization. And there's some data exchange standards, transaction information and statements, and a history that will be used and transferred through 2023. The labeling obviously was traumatic for people who worry about pharmaceutical labels. You had to make a lot of room on a label that's probably already very crowded. That will tell you a little bit about what they had to go through to make this work. So let's talk about dispensers and what your obligations are. Now, as you know, there's different kinds of dispensers. I talked about physician dispensers, and they have obligations too, but pharmacist dispensers have 5, whereas all other dispensers have 2. So the first obligation that all dispensers have is to only purchase from authorized trading partners. That means you are obligated to check the licenses, check that they're in force, and keep records of that. So for a pharmacy, this is not a big deal. You probably already do it. Maybe you don't keep great records that you checked a pharmaceutical wholesaler's license, but as you heard from me, there are other entities that don't. You must only trade products that have identifiers unless they're exempt or grandfathered, and there are some that are exempt. And then for pharmacist dispensers, you must participate in product tracing, and that means you must capture and store that information and then transmit it if you sell the product on to somebody else. You don't have to give it to patients, so that part is not part of your issue, or not part of your obligation. If someone asks you for information about a product they're tracing, you must respond to that request in a statutorily defined short time frame of, I think it's 1 to 2 days, business days. And then if you receive product that you consider suspect product, I'll talk about how you hit that bar. You must quarantine it and investigate it and verify it, and then either take it out of the supply chain forever, or you can put it back into the supply chain and notify everybody that you worked with that it was cleared. So those are your 5 obligations. Trading only with licensed trading partners should not be a surprise, but the FDA does have a publication about it, and you can go and look at it. It's a draft guidance document, but I don't think anyone expects it to change a lot. And this document basically tells you how you identify and what a licensed wholesaler looks like, or what a licensed manufacturer looks like. And it's meant for everybody in the supply chain to understand how you can identify a licensed trading partner. Another obligation I mentioned that all dispensers have is only trading serialized products. A serialized product has those 4 numbers that I'll explain in a little bit in the barcode, but that's not the only kind of barcode that you will find on medicine. This is actually a vial of the Shingrix vaccine that I made the nurse who gave it to me show me so I could take a picture of it. It's got a barcode, but it's not a serial number. That vial is part of a larger kit that has multiple vials in it, and that kit is in fact serialized. This is an example of a fake drug that I put together a label for, and then I put a label on. And let's just take a deeper look at this label. You are already familiar with lot and expiration. Those have been on medicine for a long time. I don't need to explain those to you. The 2 new numbers you'll see along with the barcode are a GTIN, which identifies things like manufacturer and relabeler and the unique product number. So it's all those things wrapped into one, sort of like a super NDC. And then there's a serial number that is unique to that package. If what comes off the factory line at the pharmaceutical manufacturer is a 500 count bottle, that's got 1 serial number. If what comes off the factory line is an HIV medicine in a sealed bottle that has 30 tablets for 1 month for a single patient, that has the serial number. It's whatever is the smallest saleable package that is sold. And again, you're not required to pass this on to the patient, although some people have told me that they're seeing serial numbers on their patient-issued medicine. There are some things that are not required to be serialized, and that's not expected to change in the future, and it's listed in the statute. I'm not going to go through in great detail, but these are the items, exactly the language from the statute that's not required. And there's some different techniques for serializing larger cases and pallets of medication that I will not go through, but just know that that's the thing that happens. So let's talk about the participating in product tracing. Lot level product tracing has been required for a while, but in November of 2023, you'll be required to receive and store that serialized data. If you buy something today from a lesser known wholesaler, one of these gray marketers, you'll probably get an offer to give you their transaction history, and you'll get it, and it'll go all the way back to either the first wholesaler or the manufacturer. But come November 2023, it's likely that all you'll get will be the previous step that the gray marketer bought it from. You won't get a full transaction history, which is a little inconvenient if you suspect the product and have to do a product trace. But typically the way it works is that someone in the supply chain suspects their product. Maybe it's you, maybe it's actually an investigator, but you basically contact an entity in the supply chain and you say, I need to know where you bought this from, and I need you to confirm that this is the serial number and this is where it went and this is where it came from. That's about all it takes. And if you have suspect product, it is a time sink. I have to tell you, I think that is something that will majorly affect your pharmacy operations, because there's a lot of work that goes into it. If you get a product that has 5 steps in it, right? Gilead, AmerisourceBergen, wholesaler, you're going to have to make 5 phone calls. You're going to have to send out 5 emails. You're going to have to do 5 tracings and then just compare and say, so-and-so said they got it from Gilead on this date and this is the serial number. Is that what Gilead told me also? Right? You have to actually do the work to clear that product out of quarantine. And I think that's going to be a time sink that people are not going to be comfortable with. And that obligation is today. You have that obligation today. That doesn't wait until November to come into effect. So let's talk about what is suspect and illegitimate product. It can be product that you suspect to be counterfeit, diverted, stolen, adulterated. If you think that it's the subject of a fraudulent transaction, if you look at it and you're like, this is, and you just absolutely know this is the real thing, but that entity lied about buying it from that other entity, that is still suspect or illegitimate product. And if obviously any of those things are true, it's unfit for distribution. It is not, it has been basically diverted out of the legitimate supply chain. And again, the only difference is suspect product is product that you haven't verified yet. Illegitimate product is that product you verified that is, and you've confirmed not real. So as a pharmacist, you may think to yourself, okay, this seems all very subjective. How do I know if this thing I got from a gray marketer is illegitimate? Or even, how is this thing I got from one of the big 3 wholesalers? How do I know if I should suspect if it's legitimate or not? And the way you do it is you start with this FDA publication that basically tells you the reasons that you should use as a basis. And you should make sure that everybody in your shop that has anything to do with either ordering or receiving is familiar with the standards in this publication, because you'll be held to them if a product turns out to be suspect and someone asks why you didn't quarantine it and investigate it. And they're pretty, if you're a careful conservative pharmacist, which many of the pharmacists I've met are, they're very concerned about the safety of the medication they dispense to patients. None of this is going to be surprising, right? Packaging errors, missing packaging, odd lot and broken lots and cases being sold, stories and prices that seem too good to be true are all going to be causes for you to suspect a product to be illegitimate. So what is the procedure that is statutorily required of you? You have to take everything in your possession that you think is suspect and quarantine it. It cannot be dispensable. It has to be in a secure location. And if you get suspect product from a gray marketer and you've got previous product they've sold you on hand, you're probably, to be safe, going to have to quarantine all of it. You must now notify all the trading partners that you're conducting an investigation. And so the manufacturer would be the first one I would call, and then everyone in the transaction history. You must verify serial numbers, lot numbers, and the GTIN product identifiers for at least 3 packages or 10% of your suspect product. If you have only 3 units, then you're checking all 3. If you've got 100 units, you're checking 10. You can't use the 3 rule. You have to do all of them. And you have to check the transaction history. So you have to talk to every entity that it came through and the transaction information that you've been given. And at any point, if you find something that doesn't add up, you can stop, because that means it's illegitimate. And you have to keep records of this investigation you did for 6 years. 6 years. And at the end of this, if you find nothing wrong, you put it back into the supply chain. You can dispense it, it's cleared product, and you let everybody know. If it's illegitimate, you've got to let all the trading partners know that it's actually an issue. If you do find that it's illegitimate, there is not surprisingly a government form that you can fill out. It's the FDA's 3911. you can fill it out as a fillable PDF, and then there's instructions on how to submit it. But you probably should not return it to the wholesaler. That is the big thing. If you return it to the wholesaler, it's going to get turned around and resold back into the supply chain. And if you found that it's not safe, you're only endangering some other pharmacist patients by sending it back to the wholesaler. One of the questions that people have as they start to realize the scope and breadth of this is that this could be very time consuming. And one of the ways to shorten it is to go to the protection department of a manufacturer for the product and see if they will offer to check it out for you. Gilead actually has a standing offer to validate and do a full trace for any pharmacy that calls. So you can actually use that as a crutch to try and save yourself some time. Regardless, almost everyone in the supply chain has a very short time frame for what they have to get back to you. So at least it's not like you're going to be working on this for a month waiting for callbacks. There are new IT systems coming online that are supposed to be able to do this tracing with the push of a button. I think it's not going to be November when that happens. It's going to be a little longer than that. There are some questions about like how much will a pharmaceutical wholesaler help you with? What are they obligated to do? The HTA has a handout that explains what wholesalers are both obligated and expected to do and what they are not. And you can download that from the HTA's website. There's a picture of it here. I apologize, there's not a link on this page or a QR code. I'll fix that. But mostly they can expect to store transaction information for the products that they sold you, not from something you bought from a gray marketer. And they'll also be doing testing and training with your on-premise systems that talk to their IT systems. But they're not going to do the product trace for you. That is not an obligation that they have. And they're also not expected to keep any records for medicine that you bought from a gray marketer, of course, or do the quarantine storage for you. That's not something that they are willing to take on. All right, so let's do an example real quick here. This is this one. This is from Gilead Sciences to AmerisourceBergen. Here's another one, which I think is an even better example, where that you get a transaction history for a medicine that Gilead Sciences sold to cheapo wholesale meds, and then it came to American Wholesale and then Joe's Meds, who's selling it to you. So you look at this, and one of the shortcuts, I would call it, one of the things that counterfeiters hate, is that companies like Gilead have a limited distribution list of first sales, right? Gilead doesn't sell their product to just anybody. There's less than 20 entities in the US, 20 wholesalers that they sell product to. You can find the list on their website. And I can assure you that a company called Cheapo Wholesale Meds is not on that list. So if you get a transaction history and you look at the first sale after Gilead and that wholesaler is not on their limited distribution list, you can stop. This entire thing is fraudulent from that moment forward. Here's an example of Gilead's website where they list for different products who they sell to. This is not the complete list, but you can take a look at that list. And if you look on this list and Cheapo Wholesale Meds, that first sale wholesaler, is not on the list, you're done. What you're holding is fraudulent. It's either diverted or counterfeit, but it's not safe to give to patients. Quarantine it and file your 3911 and let everybody know, because you got a criminal on your hands. When you do these requests, manufacturers, wholesalers, and repackagers all have 1 to 2 business days to respond to you. That is written in the statute for any federal or state official. And as a pharmacist, it's probably not hard to get a federal or state official to help you, especially from the Board of Pharmacy. When people ask you these questions, you've got 2 business days to answer it. Some people have asked me, and I think it's a reasonable question, how does this affect returns? If it's a saleable product and you're doing a return, you don't have to provide any of this DSCSA data if you're sending it to the same person you bought it from. If it's not saleable product, You can provide it to this list of people: manufacturers, repackagers, wholesale distributors, where it came from, returns processors, or a person acting on behalf of those without having to provide any of the transaction information. So again, I mentioned before that it seems like the system was architected to give pharmacists the easiest implementation, and I do believe that that is true when you look at details like this. We haven't seen anybody prosecuted for the crime of violating the DSCSA or fraudulent transactions yet, but there's some fines involved in it and jail time. However, that's probably the least of your problems. You're going to get a Lanham Act prosecution out of this if you're egregious with patient safety, and you'll probably get sanctions from your board of pharmacy. All of those things are not welcome. I mentioned before the Lanham Act, going to do this here. I just want to mention one more thing before we go to questions, which is, as we head to the November deadline, when product tracing is supposed to be an obligation for pharmacies, you may have some IT questions. I think you should ask the people that provide the software that you use in the pharmacy about what their plans are for DSCSA compliance, but that's not going to be where your work is. What you should be doing now is putting together a policy and procedures manual for your staff that talks about how you check in product, how you identify suspect product, and how you quarantine and investigate product. You're going to need that so that when, and hopefully never, but if counterfeit or diverted product passes through your hands, your pharmacy is protected if it was the policy of the pharmacy to do this, and then it becomes specifically an issue of employee training or a rogue employee. You want to protect the pharmacy first. Let me jump a little bit and go to some resources and answer questions. If you want to learn more about DSCSA compliance, all the major pharmacy organizations and the HDA have put together a website called dscsa.pharmacy that you can check out, that explains how you, what their perspective is on compliance, some webinars that explain more information. There's also a book, if you're really going to be nerdy about this particular law, that Dirk Rogers wrote that explains it. And then I mentioned Dangerous Doses, which is the story about the Procrit and Epigen case that happened in the early 2000s. So I'm going to go to questions. Throw them in the chat for me. I think I missed some earlier, so if your question didn't get answered, you can repost it, and I'll do my best to answer it. The first one I see is from Amy. It says, how does this affect locations that purchase drugs that do not have pharmacies? So if your entity presumably dispenses because you're purchasing drugs, you have 2 of the 5 obligations that apply to you. You must purchase only from authorized trading partners is the biggest one, and you must only purchase serialized product. So if you purchase and dispense a blood thinner and you're dispensing it and you don't have a pharmacy. I don't actually know how that would work. But if that was the case, you must make sure you only purchase from licensed entities, and you must only purchase products with serial numbers on it if that product is serialized. You don't need to participate in product tracing, and you don't need to actually then do investigations. Here's a question that I'm absolutely stumped by. Is how does this apply to veterinary pharmaceuticals? And I don't believe that the DSCSA applies to veterinary products. But it occurs to me I'm not entirely sure, but I don't think it does. And so I don't think that veterinary practices are affected by the DSCSA. The next question is, we buy direct from manufacturers in cases. I'm assuming that is in not specific cases, but is in volumes of cases. Are we required to scan each bottle within the case, or does the case barcode include the serial numbers for each unit in that case? That is a question that is going to be answered by the manufacturer that produces the software that you use to run your pharmacy in premise. The DSCSA does allow for an entire case of medication to be serialized and contain and transmit all the serial numbers of the bottles inside. So it is possible, in theory, in the design of the system, that you could scan the case and you could bring into your system all the serial numbers of the units in the case. But I cannot tell you for sure if it'll work that way. Depending on your software provider, they may make you open up the box and scan each one.
Shabir, there was a question further up top. Michelle asked, for patients who are receiving an infusion, is there anything they should be looking for to know that their infusion center is getting the medication from a reputable place?
So this is something I'm obsessed by. Every time I go and get a vaccine, I make the nurse show me the bottle that the vaccine came out of. And as you saw with the Shingrix vaccine, it kind of failed because the bottle itself is not serialized. The whole package of 10 bottles is serialized. If you are in a situation where you're getting an infusion or a vaccine, you can ask to see the product. That's an unusual thing, but you don't really have a lot of recourse as a patient to protect yourself. I think in that scenario, you're really operating on the trust of the dispensing medical practice that you are using. And I'm sorry that's not a more satisfying answer, but there is a certain amount of the system that runs on trust. You could, if you wanted to, look and see if that particular entity has a warning letter from the FDA or any prior warnings. Just 2 months ago here in San Francisco, a cosmetic physician was buying black market Botox and injecting it into her patients, and she just pled guilty to doing that. That would be an example of something that you as a patient can investigate and learn about that would cause you to maybe not use that particular practitioner. But beyond that, it's difficult for a patient to do product tracing on an infused or injected product like that. There's another great question here. If after investigation it is determined to be a fraudulent product, is there a requirement to notify the FDA and or law enforcement? The answer is yes. You must notify every trading partner. So everybody that you know that handled the product, starting with at least the manufacturer, must be notified. And if you sold it to another pharmacy for a named patient need, you would have to notify them. You'd also have to notify, ironically enough, the wholesaler that sold it to you. And if they're a gray marketer, the answer is they probably know it's already illegitimate product and you're not telling them anything new, but they're uncomfortable with the fact that you now know. But you're going to have to notify them. And yes, you have to file a Form 3911 with the FDA. The FDA has the Office of Criminal Investigation inside of it. They are law enforcement. I don't know if they carry guns, but they most certainly carry badges. And there's a couple of criminals I know of historically who couldn't believe that the FDA had special federal agents as they were being arrested. They didn't think it was possible. Here's another great question. Using your crystal ball, what kinds of workarounds do you think may emerge beginning in December 2023 after it goes into effect? That's really interesting. Right now, if you talk to your software provider, they will probably tell you they don't actually know exactly how DSCSA integration is going to work. Because at this moment, they're probably just starting to have their systems talk to the IT systems from AmerisourceBergen and McKesson and others. They don't even know, they may not even know if the system is working. And so it's true that they don't have a lot of visibility. I think what's likely to happen is that we're likely to see enforcement postponement in December of 2023, but not the obligation to get it done. And the last is, are diabetes products, meds, and supplies affected by this, or even inhalers? I believe inhalers are serialized. I believe that diabetes medicines are serialized. I don't think, my memory is that test strips are not a product that is serialized, but I have to double check. To clarify, health services with no pharmacy have no responsibility of trace and tracking. So health centers Health services, if they don't dispense, they have no obligations whatsoever unless they resell product at like a wholesaler. If they are dispensers but not pharmacist dispensers, they have only a responsibility to only buy from licensed entities and to only purchase and dispense serialized product. That's all the questions we have, and it's also 10:31. So David, I hope I've done you justice on your schedule.
Yes, Jabir, thank you very much. This has been wonderful. Very, very informative. A lot of really good questions. Lots of things that obviously I would never know. But I think even for folks who are pharmacists, this is all a lot of the behind the scenes stuff that's really, really important. So thank you.
Thank you.
Now I'd like to. And now I have the privilege of introducing our final panelist, our final speaker for the day, Dr. Michelle Durham. Dr. Durham is the Chief Behavioral Health Officer at Ibn Sina Foundation and a pediatric and adult psychiatrist. And just so you know how lucky we are to have her, around this time last year, she was testifying in the United States Senate before the HELP Committee on mental health and substance abuse crisis that we are in the midst of. So we're very, very fortunate to have her speak to us today. And I hope we're a better audience than the US Senate, or at least the Senate committee.
Thank you for that kind introduction. I'm having some connectivity issues, so I apologize if for some reason you lose connection with me. But
so
all that being said, can you hear me okay?
So it all looks good.
Okay. So I'm really happy to be here with you all today. I'm going to talk a bit about the child mental health crisis that we're in. I think of some challenges, but also, hopefully leave you with some areas of opportunity and also what we're starting to do in at least the mental health space and trying to meet this challenge. So I'm going to discuss the current child mental health crisis a bit. I'll review some of the best practice treatment guidelines in child mental health for some of the key areas that we see, especially as we think about primary care in general, but also thinking about every single person on this call may be impacted, whether directly or indirectly, and sort of how to view that and how we view that in the field too. Specific tools to help patients and also yourselves manage mental health issues, a crisis or not. We will all have some days that maybe we're struggling, and sort of what you can do. And for those who have little ones at home, what that might be like as well in general. And then last but not least, I mentioned identifying programs and other resources that you can utilize when counseling patients. So why should we care? I've alluded to this in the first few seconds. Globally, 1 in 7 10 to 19-year-olds experience a mental health issue. This accounts for 13% of the global burden of disease in this age group. Depression, anxiety, and behavioral disorders are among the leading cause of illness and disability among adolescents. We know that suicide is the 4th leading cause of death among 15 to 30-year-olds. And so, kind of why is this happening? Adolescence, I think, hopefully we can all sort of remember that time, whether there was extreme struggle or not. It is a time where you're trying to figure out your identity, trying to not have your parents involved with every aspect of your life, where you feel like your friends are everything. But this also leads to a lot of vulnerability of feeling maybe excluded from a social group or friendships. People don't like you, or feeling like you're discriminated against. There's a lot of stigma around mental health, as probably many of on this call today know. Educational difficulties make you more vulnerable, the lack of understanding in the classroom, or feeling like others are getting it and you're not. There's a lot of risk-taking that happens in adolescence in general that just makes you more vulnerable, and depending on that friendship group, and if you're a parent or an aunt or an uncle on the line, that how much friendships in that adolescent group, how much they might listen to them and not listen to the adults in their lives, and then take risks because of that. Physical illness, and then there's also just globally a lot of human rights violations that impact young people. So the consequences impact us all, really, when we fail to address not only adolescent mental health, but child mental health in general conditions, because they extend into adulthood They impair physical and mental health, and they really limit opportunities for people to lead fulfilling lives. One of the studies that I'm not going to get to today, but there's the Adverse Childhood Experiences study that was done back in the 80s. And it was out at a Kaiser, actually, in California. And it really points to this last point on this slide, in that they essentially just gave a 10-question questionnaire to people coming into the primary care clinic and asking them about things that happened in their lives growing up that were challenging. Divorce of a parent, maybe a parent that had a substance use issue, maybe a parent that had been in jail, a parent that had a mental health issue. And what we know from that data back in the 80s, and is still very true today, that even if people didn't reach out for mental health help, and they were impacted by this stuff that happened in their childhood, the physical consequences were there. So we see increased rates of heart disease, stroke, diabetes, cigarette smoking, alcohol use, that impacts our physical health when those things were not addressed in childhood. So it's important. We see the consequences financially, if that doesn't get you, that we all have to contribute to as a society when we don't take care of folks when they're young. So mental health is an important part of children's overall health and well-being. This includes children's mental, emotional, and behavioral well-being. It affects how you think, you feel, you act, plays a role in how people handle stress, relate to others, and make healthy choices. Mental disorders among children are described as serious changes in the way children typically learn, behave, or handle their emotions, causing distress and problems getting through the day. So I'm a child psychiatrist. I am seeing those folks that are at the end of their rope, if you will, that have serious changes. And what I encourage all of us to do is to think about at the prevention and promotion at the beginning, of that continuum, if you will. How do we intervene early so that I'm out of a job essentially, and that I don't need to see when it's serious, when all of those years of folks saying, I'm not quite right, of a kid expressing some type of distress and we don't get them help or intervene early. The Surgeon General this year, and I'll have a couple more things from him too, Vivek Murthy, at the end towards, I wouldn't say end, but after a couple of years of the COVID-19 pandemic, came out with a report, because we know that probably all of us were impacted in some way, but young people in particular were very much impacted in this pandemic when their social lives are so intertwined with school and seeing other kids and seeing their friends. And so we could probably relate to all of that at some level as adults as well. But there are many factors, at the individual level, but the family, community, environment, and societal level in which people are impacted, and young people in particular. Relationships and neighborhoods and policies that we make as a society all influence our mental health and our well-being. And so I encourage all of us, even though maybe you're not practicing as a mental health provider, that there are other ways to think about this at a national level, at a community level, about how we can advocate for safe neighborhoods, green spaces, healthy food and housing, and think about how we interact with others in our community. How do we view people from different cultures and communities, and how that our lack of interaction or our lack of thinking of those folks as human like each one of us, how that can impact someone's mental health. And so this particular graphic came out of that Vivek Murthy Surgeon General's report at the end of 2021 on how we as a society need to essentially do better. So I'm going to take you into thinking about this by the numbers and how mental health affects kids across the lifespan. And so ADHD, attention deficit and hyperactivity disorder, no longer called ADD. So if you hear folks saying ADD, we do not use that terminology anymore. You either have attention deficit hyperactivity disorder, the inattentive type, you have the hyperactive type, or you can have combined inattention and hyperactivity. 6.1 million children nationally between 2 and 17 years of age have ever been diagnosed with ADHD. For anxiety, about 4.5 million kids between 3 to 17. We see higher rates of anxiety disorders among Black children when compared to white children. Depression, 1.9 million children between 3 and 17 years old will have or have been diagnosed with depression. I'm going to talk a lot about the COVID-19 pandemic in particular. I know folks feel like it's over nationally, but I do think that there's a lot to say from a mental health perspective of, yes, maybe we have found ways to reduce infection nationally, but the mental health burden of how this impacted folks over the last 2 to 3 years is impressive. And I think as mental health clinicians, we're still going to see a lot of this play out. And with our frontline, people that worked in hospital systems, I think we'll see likely a lot of post-traumatic stress disorder that just hasn't come to light fully. But with that being said, this pandemic led to an increase of depression, anxiety among children of color in particular, between 5 and 11 years old. The rates of depression and anxiety problems increased 5% before the pandemic to 18% during the pandemic. Pretty startling numbers. But if we reflect on those first few slides that I mentioned earlier, when schools shut down, when lack of that sort of social cohesion, thinking about their friendships, thinking about all the things that you get from school besides just the learning, just a significant impact on young people in particular. Let me go back one slide. And to say that, I've highlighted, and some of the literature has highlighted communities of color. And when I say that, it's not just communities of color, but folks also that come from a low socioeconomic status, no matter color. Those were folks that had to continue to working 2 or 3 jobs, that did not have the ability to maybe stay remote. And so, or live in multi-generational homes. And so maybe grandparents, aunts and uncles were in the home too with the kids, and there were primary providers going out and still working during the height of COVID-19. And so there was a lot of, lack of, the adult supervision, but also a lot of bringing maybe some of the infection back into the home. And so a lot of lives lost, which I'll talk about too, and we think about grief during this time. Overall, depression, anxiety, behavior disorders are more prevalent as kids get older. So 3 to 5-year-olds can get depressed. Want to highlight that a bit. We kind of think that it's only teenagers or adults that can have depression. What we do know from a lot of the research at this point in time is that when 3 to 5-year-olds get depressed, it's because of the environment, meaning their home environment. And so we have to spend a lot of times actually with parents, caregivers, to help improve their mental health in order to support their little ones. It's where a lot of the treatment happens. But you can see that large, bump into 12 to 17. So young people, those teen years, you see a lot more depression, anxiety in general. You see more behavioral tantrums, outburst, if you will, in that 6 to 11. So that we think of that as school age, which can come from many different factors, from learning, ADHD, could be depression, but behavior disorders in particular, we always are trying to figure out what the source of the behavior is. And as a child psychiatrist, likely for adults too, behavior means something. And that's what clinicians who work with young people are always thinking about. What does this behavior mean for this young person, and how can we help them? Just more stats to hone in this message. 1 in 5 kids ages 13 to 18 have or will have a serious mental illness. 1 in 5. So someone on this, are in this conference today has children around them. You think about 5, 6, maybe cousins, nieces, nephews. 1 in 5 will have some type of mental health issue in their lifetime. About 10% of youth have some type of mood disorder. 10% of youth have a behavior or some type of conduct issue. When we think about that as like getting into trouble sometimes with the law, not really listening to authority figures or adults in their lives. About 8% of youth will have an anxiety disorder. This is have or will have a serious mental health issue. The impact is super important. And I always qualify this in presentations, like we know that about 50% of all lifetime cases begin by the age of 14. Most people will tell you, even if you see them at 25 or 30 years of age, I remember not feeling well around 13, 14 years of age, about 75% by the age of 24. And when I say that, by 14, someone knows, like, I didn't feel great. I didn't have a name for it, but I know I withdrew. I didn't want to hang out with my friends. I did things differently. My grades dropped. It takes 10 years on average between that onset of symptoms and the intervention. I don't know any other medical diagnosis where we wait 10 years in order to treat folks. And so there's a lot we can do at a societal level, because some of that is definitely stigma. How do we share more of our stories? How do we all become more vulnerable of thinking about, there are times in our lives where it didn't feel well, or maybe where you did seek a psychiatrist or a therapist, someone in the field to get some more support outside of your immediate family. But there's a 10-year delay. 30% of students with a mental health condition age 14 or older drop out of school. This is the highest dropout rate of any disability group. About 70% of youth in state and local juvenile justice systems have a mental health issue. So many of us are thinking a lot about how do we have a less punitive approach when kids are out of control or have some behavioral
Michelle, you're breaking up a little bit. But we'll give it a minute and hope you come back. Uh-oh.
Sorry, I think I cut out, so I will get back to it.
Oh, good, you're back.
About all of these things end up, we're thinking a lot about suicide. Yeah. Sorry if that happens again, I'll just do my best to pick up. So all of these things that I've mentioned so far is that suicide, though, is a huge risk and the leading cause of death in people the age 10 to 24, a huge problem, which is why intervening early is so critical. 90% of those who have died by suicide had an underlying mental health issue, why there's much work to be done. As we think about the Pew Research Center looked at like, how do teens see other folks in their high schools and think about the teens that they're hanging out with. And so this was an interesting study because it's not clinicians or providers or adults in their lives. It's literally peers saying, hey, somebody in my peer group or in their community where they live had anxiety and depression. They said 70%. That somebody in their peer group experienced bullying. But you can see there's a long list: drug addiction, drinking alcohol, poverty. But anxiety and depression are what teens are seeing from people in their community that are their age. I'm happy to go off camera if that feels like it might be better. So I can do that. That's a good suggestion. So child mental health and the COVID-19 pandemic. I wanted to talk a little bit about this because it's so prevalent in what we've seen in child psychiatry world in particular. So a coalition of the nation's leading experts in pediatric health issued an urgent warning declaring the mental health crisis. So this was the American Academy of Pediatrics, the child psychiatrists, the National Organization, American Academy of Child and Adolescent Psychiatrists, and also family physicians. That it was a national emergency. What we saw in 2020 is that the percentage of emergency department visits for mental health emergencies rose by 24% for kids between the ages of 5 and 11, and 31% for those between 12 and 17 compared with 2019. I mentioned earlier about kids of color and the some from that percent of the population, had lost a lot of caregivers. About 140,000 kids lost a parent or grandparent during the pandemic. And this number continues to grow. Native American children were 4.5 times more likely to have lost a primary caregiver. Black children were 2.5 times more likely, and Latinx children nearly twice as likely. I say this because we'll talk a little bit about certain diagnostic areas, and grief is one that we really have to think about now that we're all back at work or back in school, but children are still dealing with many losses that happened during this time. Many of you may think, have seen too, like in and sort of the media and the news, that it just feels maybe like there's a lot of trends in that this is like increasing mental health. So why are what's happening? There's many hypotheses. It could be that young people are just becoming more willing to openly discuss. And so maybe our numbers aren't, maybe they were like this years ago. It's just that we just didn't know about it. Young people are definitely more open than older generations of discussing their mental health concerns. Growing use of digital media, right? We are seeing a lot of this, and the good, the bad, and the ugly of being on social media in particular, especially for young people. There is an increase in just academic pressures. There has been a limited access to mental health care. And so we have these growing demands. People are being more open. People want treatment, and yet there's not enough of us in the field. So as a child and adolescent psychiatrist, there are about 8,500 of us nationally. We have statistics from our National Organization of American Academy of Child and Adolescent Psychiatrists that to meet the demand currently, we need in the next decade at least 35,000 child psychiatrists. That is just for psychiatry, but this trend is true for psychologists and social workers, that there are not enough of us to meet this demand, which is why we're looking for other folks in the field and in primary care, and in thinking about schools and thinking about more prevention promotion in order to reach kids. There's a lot of health risk behavior such as alcohol and drug use happening in general among youth. And then there are broader stretchers, thinking about financial crisis that are obviously, we talked about how in that initial graphic with the Surgeon General, that things that happen in society and communities, it's not just about the individual level that will impact someone's mental health and their well-being. Income inequality, racism, and thinking about the pandemic, and many have said that there were two pandemics. One of thinking about this reawakening the country had to racism and how that affects people of color, and then also thinking about the COVID-19 pandemic. But gun violence, climate change, and I'm sure there are many other things we could think about of all the other factors that come into play. Treatment and prevention is critical though, and you'll hear me say that time and time again. These disorders are prevalent. I've shown you some numbers. They can be recurrent, especially untreated, have high rates of comorbidity. They are accompanied by poor psychosocial outcomes. So what we see is that people don't reach their full potential. We showed I showed some dropout rates in high school of not completing certain, even if they attend college, maybe not completing. So there's a lot of societal, financial things and that impact their ability really to lead fulfilling lives, associated with the high risk for suicide and also a high risk for substance use. So then when we don't treat, what we see is it impacts work productivity. And many of us probably have colleagues that maybe we don't know what's going on, but we do know that they are missing a lot of days. And sometimes we don't know the why and what's going on for them. But it behooves all of us to think about it in that framework, and not that the people are just lacking the ability to work or they're being lazy, but thinking also about what else could be going on in their lives. Incarceration, high rates of incarceration when we don't treat mental illness, high rates of incarceration when we don't treat substance use disorders. There are a lot of chronic medical conditions. I mentioned the ACEs study through Kaiser in California, and that really showed us all the medical conditions and comorbidities that happen from untreated mental health issues. Family and community disruption, the academic achievement, poverty, and suicidality. So sort of what are our best practices and some of the things that we look at from a symptoms viewpoint when we're thinking about assessing child mental health? Key to treatment and what happens, and so I'm hoping to demystify for some folks too of what happens when people come in for treatment. I think TV, social media, and other things sometimes make it seem as though everyone is just coming in and laying on the couch, right? Or getting some type of shock treatment. That's what you hear a lot in TV and news. But it's really a collaboration. True mental health treatment is really about collaboration with the child and family. And really focusing not only on what the presenting problem is, but also what are the strengths? What do you like about your child is one question I love to ask during some of our sessions. What are the things that are going well? So we collaborate a lot with different systems as well. Kids are a part of many systems. They're a part of the family system, but they're also a part of the school system, other community agencies, government agencies that may be involved with the family. We want to ensure that functioning outcomes are a goal. So what that means is that if they come in and they're already declining in school, grades have declined, their relationships have declined, that's part of what we think of in the mental health field as functioning. There's been a functional decline. The DSM, right, is the book that we use, is our guide for thinking about disorders and symptoms. Every single disorder in the DSM, the last piece, the last bullet point, if you will, always says, how is it impacting functioning? Because that is, some people may not have every symptom, for example, of depression. They may not meet full criteria, but it's really impacting their functioning, the symptoms that they do have. That means we should treat, we should do something. And that's the end goal, that they have improved and have success in school, relationships, and in their communities. There's a continuous part of evaluating and modifying the treatment plan. So whether it's a psychiatrist, if there's a psychologist on the team, or a social worker that's doing the initial evaluation, they're really thinking about, okay, these are the main symptoms we're targeting, and what will be part of the treatment plan in order to get folks to be functioning in all aspects of their life. Medication is a part of that, yes, but also there's a lot we can do in schools. There's a lot we can intervene in home from a therapeutic standpoint, and also at the individual level with that young person. And some of that is also, the last part is also maybe family intervention. There are many dynamics in families that happen, and sometimes there's a kid in the family that's sort of identified, quote unquote, as the problem. But as we start talking to the families more, and the caregivers, or whoever's involved in the kid's life, you realize a lot of dynamics at play. And then we always are thinking about, well, what's the most appropriate setting for treatment? Many states, but not enough, have a lot of school-based services that we can implement. Massachusetts in particular has a lot of in-home services. So actually therapists, mentors, care coordinators actually do a lot of treatment in the home. And then obviously there are a lot of community agencies that kids can just literally walk down the street with their family to get some services, and not necessarily always have to come to academic centers or hospital systems to receive their care. Timeliness is also key. You know, I've said a few times about prevention and promotion. You know, I feel like a part of my job is trying to help communities, schools, primary care providers, how to assess, diagnose, and treat much earlier and be more timely in that evaluation than waiting to see a child psychiatrist or psychologist. And at this point that we all have really long wait lists in order to see folks. And then we always need to think about in our assessment and treatment, how do we tailor services to the child and family based on cultural and linguistic needs, which is very true. And sort of, I switched roles in the last couple of months, but my role at Boston Medical Center and my new role here in Houston, it's a really diverse patient population. And I always had to remember to bring in the culture, value, thinking about people's religious background, and how do we bring that into part of the treatment planning? Because at the end of the day, folks won't do things if it doesn't align with some of their core values. So I'm going to go in and talk briefly about some of the things we see frequently, some of the things we're seeing a lot now because of what's happened during the pandemic, and also giving a bit of guidance of how I think all of us, even though all of us here today, can really play a role in thinking through this, or maybe even thinking about your family, but thinking about people that you see in whatever setting you work, and how we can intervene and offer even some support. So normal fears or anxiety. When we think about anxiety, they are among the most prevalent problems affecting kids. They can interfere with functioning in a wide range of domains. Left untreated, anxiety disorders tend to persist. They can worsen and can lead to other forms of behavioral health disorders or unhealthy coping strategies. Maladaptive levels of anxiety can interfere with somebody's ability to enjoy everyday life. So many children actually never receive appropriate help for anxiety and I think a big reason for this, because it's such an internal process and feeling. You generally don't see this is a kid that's not disruptive, if you will. And so in class, a teacher may say, oh, they're like the best kid because they never talk, they never get a class, they never ask questions, they just do their work and they're sort of silent. In a class of, of 30, a busy teacher may feel like, hey, that's not a problem for me. It's the kids, right, that are running out, being really disruptive, that come to the attention. But even in a primary care provider's office, it doesn't always come to attention because they're sort of quiet. Maybe they think they're shy. People aren't really thinking about anxiety being a major issue. And so unfortunately, it's when it gets to really unhealthy coping strategies, sort of refusing to do certain things, that it comes to the awareness of sort of everybody, family, school, and primary care providers. So for most children, fear and anxiety are experienced without great interference in everyday life. Most fears are transient. We all have experienced anxiety in our life, and that's good. It actually motivates us to get things done. When we're talking about anxiety disorders, this is every day, all the time, multiple times a day, inability to do certain things in their life. They persist and they interfere in daily functioning and really just disrupt everyday activities, not only for the young person, but you'll also see family members talking about too, how they can't do certain things because of this irrational, right, fear that one of their family members may have. What can each one of us sort of do and think about it, in whatever setting we're in? So unstructured time can lead to increased anxiety and unhealthy habits. Creating schedules, thinking through this with the person, this may even work in a work environment too. People may need more structured agendas and understanding what their schedule will be. For people who don't have anxiety, this may feel like, oh, I can just go day to day and no big deal. Whatever shows up at my desk is fine. But for people with anxiety, this is a big deal. Encouraging healthy habits to decrease stress and worry. So this is something we all, sort of want to, quote unquote, prescribe, if you will. Exercises in the house or in the yard or, going to the gym, whatever sort of works, but can really help relieve and de-stress people. Encouraging child to stay connected with friends and family. Staying at home all day can be isolating. So with younger kids, sometimes you have to plan that time. This isn't intuitive to everybody. But if a kid is starting to exhibit those signs of like kind of withdrawing and staying home, actually what we want parents and caregivers not to do, we don't want them to what we call accommodate that behavior. We want to kind of push the kid to do the things that that seem scary. And the younger we start at this, the better results. And for all of us, whether a parent or not, in managing worries and fears and managing other people who may have mental health issues or something going on in their life, you have to remember to take care of yourself first in order to take care of family, children, or other people. This is even for the work environment. How are you handling stress and other things? If you're a manager, a leader, all the things you have to sort of think about yourself first in order to be able to help support others. When does it become a red flag and why people should really seek further treatment? People start avoiding life activities at school or home. It starts impacting friendships and relationships. Most of the time for younger kids, families will start saying like it started impacting things we were doing. I had this kid not too long ago. It was like a 10-year-old that would go to practice, mom 10 minutes ahead of time, get him to the practice. It was 10 minutes from their home. The anxiety started interfering that he felt very adamant that he needed to be at the field an hour before practice. So the family started doing that, accommodating that behavior. And so now there's a lot of going backwards because you don't want to accommodate that. What is the purpose of going an hour before and just sitting in the parking lot? There was no purpose. It was just quelling this young person's anxiety. Interference with the desire for independence. So you'll see this more in adolescence, that they'll start talking about social anxiety. So that's the time when they're going out, doing a lot of things socially with their friends. And they'll start sometimes doing negative things to quell that anxiety. So when we're thinking about that, it's maybe some type of substance use. They really want to be independent and be able to go places, and they start staying home more and not doing those social things because it causes so much anxiety and distress for them. interferes with concentration, and there's an increased depression. Anxiety and depression sort of go hand in hand in our field. And a lot of times you'll start seeing people get so frustrated with all of their anxious worries. They know it's irrational. They know nothing will happen, and at the same time, they can't stop it. And they starts affecting their mood. All of these things, it's when it really warrants further assessment and intervention. Trauma, abuse, and neglect are very common in our society. There's a lot that happens to folks in this realm. There are a lot of risk factors kids may have in their homes. If they have a parent or caregiver with mental health challenges, that is considered a trauma. We often, I think as a society, and maybe, for lay folks in particular, think of trauma as physical, right? Like a sexual assault or physical abuse, someone hit you repeatedly. But there are many reasons that kids can have what we call traumatic, stressful experiences. I am not saying that they all result in the disorder of post-traumatic stress disorder, but what I am saying that it can impact them. And sometimes people can become actually more depressed or more anxious, and not necessarily have PTSD, but can end up having major depressive disorder or some type of anxiety disorder. So other risk factors are, a child with a mental health or developmental disorder, it can cause a lot of distress and trauma in the home, and maybe actually for other siblings in the home too. If a parent or caregiver has a lot of stress in their lives, they may not be able to attune to the kids in the home. Poverty, financial insecurity is huge. Interpersonal violence between parents or caregivers in the home, obviously a very traumatic experience. Difficult parent, caregiver, and child interactions can be traumatic. There are some parents or caregivers that maybe themselves weren't parented in a certain way, and are kind of didn't have great modeling in their own life, and so maybe you're doing that with their child too. Parent, caregiver, substance use. If the parent or caregiver has a lack of social positive networks, or they're not able to feel like they're in any kind of control, a lot of this can impact the environment in the home and obviously the kids and their well-being. So those are all big risk factors when we start thinking about child risk factors. Children's stress reactions may compound caregiver stress. And so a lot of times, and we saw that you see this a lot during the pandemic, I think there was a huge rise for this as well, that everyone was stuck in the house. And so a lot of increased cleanliness or withdrawal, kids were maybe crying, whining, you couldn't send them out, you couldn't send them places to do things. A lot of, they may be feeling frustrated, they may have gotten more defiant, having poor sleep. Some type of regression. And when we think about a regression as a kid that was, maybe a 4 or 5 year old that was potty trained and doing all of those things, going backwards, having a lot more accidents. All of these can make parents and feel stressful, obviously, for any caregiver or parent, can trigger responses in them, can make them feel more sad, depressed, or out of control. I did see the question in the chat, and I'm happy to get that at the end. And folks, feel free, if there are any other questions that come up, I'm happy to answer. As we think about assessing and addressing this, we're thinking a lot about how do we sort of help people apply sort of their own, what, if you will, their own mental health support. So the caregiver is really important in all of this. And so in child work in general, we always want to make sure the parent and caregiver feel supported and that they're able to self-regulate and support their own mental health. But we're also thinking about when we're, as a child psychiatrist and as a provider for child mental health, I'm always thinking about when I'm assessing for this, and especially when I was doing more video visits as well, of thinking about how can I create a safety plan? Is the person I'm speaking with over video, are they in danger in that moment? So there was a lot we had to think about, especially during the height of the pandemic when no one was coming in for visits, of how can we identify signs of something going on in the home, especially during this time of a lot of stress. We also do a lot of checking on basic needs because we know that basic needs and financial distress causes a lot of stress, and people react and behaviors can be not great when you're very stressed as a caregiver. And so checking in on how can we provide resources. At Boston Medical Center, during that time too, there was a lot of activity in the hospital as a whole of how do we get people things that they needed, from diapers to clothing to food for people during that time. And so looking for signs, we're doing this a lot during our in-person or video visits of, is there any cuts, bruises? When we are in person, there's a lot of play in the child mental health space. When I mean play is with houses and tools and little figurines and dolls. And you'd be surprised, but kids really act out things that have happened to them, have happened to people in their family through play. And it's critical and part of our diagnosis and assessment. And so for grief, I wanted to touch on this because it's such a part of our work these days, especially, and just so important. And many of you just in life, right? Children will lose people. And so all of us can play a role in thinking about that. And how do we sort of approach it? Toddlers and preschoolers don't understand that death is permanent and that everyone eventually dies. They may ask about the return of the person, maybe repeatedly. Young children especially want physical comfort when they're upset. Some children don't want a substitute for the person they lost, and they will struggle a lot. They may become clingy and fussy. Adults can also find this, right? If the adult has also lost this person that the toddler has, they may also need their own supports to be able to deal with the regression that the toddler or preschooler is experiencing. Young school-age children do know death is permanent, but they typically think that only old people die. When they experience a loss, they may believe they have caused the death. They need reassurance from others that this isn't true. At a time when we often didn't know how COVID-19 was contracted or someone was careless, this may be true for older children and adults as well. It was very easy to blame others and ourselves. So in that first sort of year or so, there was a lot of kids that were thinking that they did something because we didn't really know a lot about what was happening in those initial moments. And this could be true for many different things, right? And not just thinking about the COVID-19 virus and how it was contracted, but for many things, young school age children may blame themselves for the death of someone. As they get older in school age, we're talking about 10, 11, 12, they begin to understand death more like adults do. They know that it's not just older people who die, they know that they can die. They may worry that the deceased person is lonely or cold. They may be thinking a lot about them and then become more anxious about that. Teens are obviously closer to adults, but in a way they will hold their feelings in a bit more. It's just not fair. Those things say that, or they didn't deserve to die. They may get angry and hide their sadness, which is key in our world a lot, like a lot of teenagers. And I actually think this is true of some adults. It's easier to say you're angry or mad than to say you're sad. I think there's some gender normative and societal normative ways that we perceive who can get sad and cry versus others. They're also typically more aware than younger children of the distress that other family members are feeling. They may appear strong and not wanting to show their pain, but how can we talk them through opening up a bit more? I'm going to skip this slide for now. A few more slides to go through. So when you think any of us can sort of initiate this conversation, how do we can express concern, be genuine with our concern, invite folks to have a conversation about this. But listening and observing, you don't have to always share everything about you. So I would limit that, but we can offer practical advice, reassurance without minimizing that person's concern, and maintain contact. I think many of us have likely been to a funeral or a wake or something, or memorial service for someone who has passed away. And many times you tell some family member, oh, I'll be in touch, I'm going to check in on you. And then maybe we forget, right? And I would encourage us all to sort of maintain contact with folks during those a year after the death of a loved one. And so we often advise to parents and caregivers that sometimes rituals are important, some type of activity to remember the loved one. And so that means, every year sort of doing something. Sometimes people just like send a balloon into the air. They have a special song or a special dinner that reminds them of some favorite meal the loved one liked. So something that just is something to memorialize this person. stories, sharing memories, help accept the acceptance of death, that people, you know, that maybe the person didn't want to leave the child, right? They didn't want to die. If people are religious. So these are all things that we can do to sort of incorporate that during times of grief and loss. Children with intellectual and neurodevelopmental disabilities who can't communicate very well verbally often express feelings in nonverbal ways. And so sometimes we see a lot of aggression or disruptive behavior. And this is true for many things, not just grief and loss. But when they can't communicate things, we see a lot more disruption, that this may be impacting their sleep, their eating, their toileting patterns. They may start doing more self-mutilating behaviors. And when I think of that too, you know, neurodevelopmental disabilities includes kids on the autism spectrum. They may be even more intolerant to changes in routine. So we always have to think about explaining things according to the child's developmental level. And we always want to sort of reestablish routines really quickly. I think it's caregivers and parents like, oh, let this just give them time, and like weeks, months will go by and they stopped going to certain activities they loved and enjoy. But the sooner actually you can get people the kids in a routine again, it's actually much better overall for their mental health and the mental health of the family. So depression is super common. Is it depression or just being a teenager is a question we get a lot from parents and caregivers, and even from folks in schools. But we're always looking at the duration of this sort of irritability or feeling sad. How severe is it? What are the other depressive symptoms? And again, that impact on functioning. Is this an AB student who is now a DF student? Is this a kid that used to go out and be involved in all these activities and now they stopped everything they were doing? They don't want to enjoy in the clubs. They stopped going to their baseball. Everything they were doing, they stopped. And you know, the caveat, we're comparing this always to peers of the same developmental age. So we're not talking about just the irritable teenager who doesn't want to clean their room and the typical stuff that we see of teenagers. We're talking about duration, severity, impact, and it's different than other teens of the same age. I wanted to go through this one in particular and the sort of the categories of what we think about clinical presentation of depression, because it is different than adults. And it's when we think a lot about thinking about medication too, especially for depression, because the result of untreated depression many times can be you know, dying by suicide. And so it's something that we need to think about critically when we're evaluating, and that it's different presentation than for adults in particular. So, you know, depressed kids and adolescents are usually more irritable. So our criteria literally says depressed or irritable mood. It's not just a depressed mood. Most teens don't come in saying I'm depressed. Most of them don't. But everybody will around them will say they're super irritable all the time, every day, nonstop about anything. But then we are looking at all these other symptoms over a 2-week period of time or more. Loss of interest, their sleep changes, their lack of energy, they're feeling guilty about things. They're not making expected weight gains, whether in eating too much or eating too little. There's a lot of thoughts of disaster, abandonment, hopelessness, thinking really negatively about themselves, can't do anything, I'm no good, no one loves me. We'll hear a lot of those sort of things. Some kids in the younger age group, but we see it in adolescents too, will do a lot of somatic complaints. It's going to the school nurse quite frequently, complaining of headaches, stomach aches, and just constantly never feeling well. Usually these kids actually get because people obviously are concerned and want to make sure medically nothing's wrong. And we'll see a lot of these kids before ending up, you know, with a child psychiatrist, or, you know, they'll have a lot of diagnostic workups, a lot of seeing the neurologist, seeing the GI doc, seeing a lot of folks before the conclusion is that these are a lot of somatic complaints as part of their depression. The functioning piece though, right, is the failing grades, as I mentioned, sort of a lot of conflicts at home and school and within their relationships. A lot of things there's a lot of environmental, so we do think there's an interplay between genetics, environment, and how does someone thinks and feels and processes things through their own lens psychologically. that influence depression. So the environment, like if there's abuse and neglect in the home, if there are a lot of school difficulties, is there some bullying happening in school, any type of social isolation. A lot of kids that are queer or on the LGBTQ spectrum, they also may experience, because I think unfortunately of society and things that are happening in society and the lack of acceptance about letting people be who they are, can influence depression. There's a lot of chronic illness, if there's a lot of family discord, but anything that has disrupted the family and parent who has a mental health issue will influence this. So I'm going to go into thinking a bit more about solutions. I'll take this question about what happens if the child has a chemical imbalance combined with the comorbidity of high blood sugar. How is the mental health affected? I'm not sure if I'm going to answer this question as best I can. I'm not sure what exactly you're asking, but we do see a lot of kids, if high blood sugar, so if this is a child with diabetes, we actually get called in quite frequently, because there is a point with a child who has diabetes in particular, where they start feeling really sad that they're the ones who constantly, if they're, let's say, insulin dependent, need insulin all the time, right? So you have 10, 12, 15-year-olds eating whatever they want, they're at school, they go to school functions, they go to school parties, and all of a sudden they're the ones though that can't eat certain things, or they have to be on a certain diet or a certain regimen, or they have to go take their insulin. We see a lot of depression in that context, actually, a lot of sadness. So can we pinpoint is this what's the source of the depression? Likely, that they're not able to, it's those environmental factors, right, that are sort of affecting. Depression can be complicated and complex. There's always this mix of sort of, is it genetic, environment, and also the way someone thinks. And when I say someone thinks, is that some of us always look at the world and maybe a problem as the glass is always half full. Some of us always may have that sort of pessimistic view of things. The glass is always half empty. And so depression has that mix that we know it's genetic, environment, and sort of how you think. And so for this kid, this example of a kid with high blood pressure, high blood glucose, has diabetes and eats insulin, and then as a couple years go by, and maybe they have to be hospitalized for this and start getting more and more depressed in this context, therapy is likely the first thing that all of us may say as child mental health clinicians. But if it worsens, or we start thinking about suicidality, or if all those functioning pieces that I mentioned before are at play, failing grades, conflicts at home and school, we will also think about initiating then an antidepressant at that point. And so I hope that answers sort of your question, but there are a lot of medical comorbidities. There are a lot of kids that have medical issues as the primary, but you're supposed to be enjoying life and hanging out and going to school. And when you start having to have a lot of consequences of going to the doctor repeatedly, maybe being hospitalized, then we start seeing, unfortunately, that depression also starts happening, which is actually no different than adults. We see this in adults with diabetes, high blood pressure, who have had stroke. And still the solution is like, can we go with therapy first and try that for a period of time? But if it's impacting functioning so much, we're going to also talk about antidepressant treatment. So in the last couple of minutes, because I want to leave a little bit of time, there are a couple solutions that are already at play, and I'm going to go over like a couple states, because it's the couple states that I've been in, and there are some other programs that are happening nationally. California is probably on the forefront of doing a lot of this work too. But it's essentially thinking about prevention and promotion, and thinking about how do we integrate behavioral health services into primary care. We cannot wait for kids to be at the end of their rope and families sort of to be at the end of their rope before they get care in like an outpatient mental health clinic. So Team Up is an initiative I worked on for the past 8 years. It is out of Boston Medical Center, funded by 2 foundations. It's a $22 million initiative to build the capacity of 7 federally qualified health centers in Boston. And really, Team Up stands for Transforming and Expanding Access to Mental Health in Urban Pediatrics. That we really want kids that come from low-income communities that typically, because they're on state Medicaid, don't always have access to mental health services, specifically child psychiatrists or child psychologists. How do we get them treatment early in the primary care setting, and that we have early identification before things even become a serious problem. The initiative integrated behavioral health clinicians and community health workers into pediatric and family medicine teams to provide comprehensive services as a part of routine primary care. And specifically, interesting enough, at Codman Square Health Center, there's also a pharmacist as a part of the team who helps with the primary care providers to think about the medication aspects of treating all of these things that I've kind of gone over. Anxiety, so antidepressant meds for both anxiety and depression, ADHD medicine, so the stimulant medication as needed as well. So those were sort of the primary diagnostic areas that we were looking at. And the pharmacist was a part of the team at Codman Square in particular to help the primary care doc to think about the prescribing aspects of these particular meds, which was a part of this initiative. So therapy is a part, contact with schools, doing therapy within the primary care setting, but the primary care provider was actually the one prescribing, if needed, a medication for a mental health issue. So within these funded health centers, there was full integration. All pediatric facing clinicians and staff use a stepped care model focusing on prevention, screening, and treatment. We trained PCPs to diagnose and manage child behavioral health concern, link the PCPs to psychiatrists if needed for consultation as well. And then any sort of outside referrals, the community health worker helped to navigate to specialized care that may be needed. Early intervention services, that's a part of thinking about prevention and promotion for kids. And then there was a lot of quality improvement that went through because there was a lot of work in the electronic medical record to help with all of this screening and diagnosing that was happening in health centers that previously weren't doing much of this work. You can find a lot of the work and to date the data in this published article in Pediatrics of how screening increased, kids were being seen same day by a behavioral health clinician, which is sort of unheard of in the field. Most kids, if they have an issue and they present to primary care, right now, most places across the country, there's at least a 6-month wait for any type of mental health treatment. And I dare to say, I don't know, this is for people on insurance, but people who even want to pay out of pocket, most child psychiatry, child psychologists, child social workers are full. And there's still a wait for even people who have the ability to pay out of pocket. This is just a lot on the who we've trained and that we really, through Team Up, there's been like this unmet, there's been a gap, right, for team-based integrated care. And child mental health, this hasn't been a part of the work. And so there's a lot of work over the last 8 years that we can start intervening quite early in order to support kids. In both Texas and in Massachusetts, there is also, Texas has gone a step further than Massachusetts in the sense of that they have T-Chat, provides telemedicine or telehealth programs to school districts. They do mental health evaluations, they do short-term therapy, their psychiatric care, all through the school system, which is where kids spend the most of their time. But what they both do, both in Massachusetts and in Texas, is a lot of consultation to primary care providers. In Massachusetts, there's also McPat for moms. So moms who just had a baby and may be depressed or have another mental health issue, how do we get them treatment early? Because as we've said, as I said many times in this presentation, that if the parent or caregiver is not well, it's going to be really hard for the family and kids in the home not to be well too. So last but not least, I just wanted to say, it's important in all of this to take care of yourself, no matter your role, that you are a role model for your children and that they are paying really close attention to everything you do and say. And how you handle stress and how you handle situations. That is all good for all of us to establish good routines, sleep, balanced meals, hydration, calming, taking breaks from social media, staying physically active, and always making that time to connect with people that support you. I'm going to end here, stop my share. Someone had asked, and I know people have to log off. Someone asked about doctors and dentists having high rates of suicide and mental health issues in the US and any other profession. And I think, what we know, and that's really very true. And I think it's a lot about stigma and also a lot about our licensing boards. I don't know a lot about dentist licensing boards, but in medicine for physicians across the US, you have to there's a lot of scrutiny when you say you have been depressed or on an antidepressant, for example, or any mental health issue in general. And so people are trying to hide it. And I think that's really unfortunate. And we all need to do a better job of advocating that we're all human. We're all probably going to come into contact with some mental health, and getting help is more important than just waiting it out. And so that's my answer to that. And I'm happy to take any questions later. David and Stephanie have my email address if people want to email me directly.
Oh, absolutely. Thank you, Dr. Durham. That was fantastic. Very informative. Also some really interesting questions and very timely. I mean, it's just the crisis in kids' mental health is just astounding. And it was probably something started before COVID, and COVID just exacerbated it. But we have a lot of work to do. But thank you for everything you do. Thank you to everyone for showing up. Let me look quickly.